Am I audible?
Yes, sir.
Okay. A very good afternoon to all the speakers as well as all the participants on day 4 of COVID-19 training. Today we are going to discuss about few topics that are important, especially in these COVID times. We are expecting the third wave of COVID. So we are going to discuss today about septic shock and its management, which is to be discussed by me only. The second topic will be ARDS and its management by Dr. Vikash Agrawal from LLRM Meerut. The third topic after lunch will be MISC diagnosis and management by Dr. Shalini Tripathi from KGMU. And the fourth topic will be PICU management, hand hygiene, general care of the patient and prevention of VAP by Dr. Sandhya Chauhan from SRMS Bareilly. After that, we will discuss about handling of disease from Dr. Vineet Singh from GSVM Kanpur, followed by post-test. So let's start with our session. The first topic will be discussed by me only. Myself, Dr. Neeraj Anand from KGMU Lucknow, Assistant Professor. So we are going to discuss about septic shock and its management. So is my screen visible?
Yes, sir.
Thank you. So the first topic of today's COVID-19 training will be management of septic shock in children. So by the end of the class, we'll be able to understand what is shock, how to recognize a patient of shock, and we will be able to differentiate between different type of shock on the basis of clinical presentation. We will be able to plan fluid therapy according to different type of shock. And if the patient is not responding to fluid alone, then what vasopressors we are going to use and what are the different inotropic therapy, how we are going to plan for inotropic therapy. So all these topics will be discussed in this lecture. Now coming on to the definition of shock. Shock is defined as a state of significant systemic reduction in overall blood flow to the tissues, and hence there is failure to deliver adequate oxygen and nutrient to meet demand of different tissues and organs. Along with that, there is also inefficient removal of byproducts of cellular metabolism. Few more definitions that we are going to discuss. Severe sepsis. Severe sepsis is defined as any life-threatening organ dysfunction which is caused by a dysregulated host response against any infection. So, a infection triggered host immune response which is leading to different organ dysfunction is known as severe sepsis. Septic shock. Septic shock is defined as when sepsis is associated with cardiovascular dysfunction. So if there is associated hypertension which is requiring vasopressors and not responding to fluid therapy alone, then we call it as septic shock. Septic shock is basically a subset of sepsis with circulatory and cellular as well as metabolic dysfunction, and it is associated with higher risk of mortality. Coming on to the pathophysiology of shock. In shock, there is inadequate perfusion, and due to inadequate perfusion, the blood supply to different organs and tissues and metabolic demands are not met. So the cells goes into hypoxia. Due to hypoxia, the cellular metabolism shift from aerobic metabolism to anaerobic metabolism, which is a less efficient metabolism. As reduced number of ATP is generated, so there is energy deficit. Along with energy deficit, there is production of lactate, and due to lactate production, there is lactic acid accumulation and fall in pH. This fall in pH ultimately leads to metabolic acidosis, and as all the enzymes as well as cell membrane are dependent on pH, so there is cell membrane dysfunction and failure of sodium pump. Due to this, there is intracellular lysosomal release of digestive enzymes. These digestive enzymes ultimately comes into circulation. These are toxic, and these ultimately leads to capillary endothelial damage, and finally to destruction and dysfunction and cellular death, and ultimately to multi-organ dysfunction and death of the patient. Now coming on to the stages of shock. In the initial stages, the body tries to maintain the fluid deficit by increasing heart rate and redistribution of blood from less important organs such as skin and GIT to more important organs such as heart and central nervous system. So in initial stages, there is compensatory tachycardia, but there is no significant fall in blood pressure. As the shock progresses, the compensatory mechanism fails, and ultimately there is hypotension along with different clinical features of shock. This is known as decompensated stage of shock. If the patient is not managed properly in this stage also, then it ultimately leads to multi-organ dysfunction and multi-organ failure, which ultimately lead to irreversible stage of shock and ultimately to death. Now coming on to what are the different type of shock. So shock could be either due to fluid deficit, which could be due to GI losses or hemorrhage, such as seen in case of hypovolemic shock, or it could be due to decreased myocardial contractility as seen in cardiogenic shock, or it could be due to abnormal vasomotor tone leading to abnormal vasodilatation and peripheral pooling of blood as seen in case of distributive shock, or it could be due to mechanical failure of due to mechanical obstruction to heart pumping of heart, such as seen in case of cardiac tamponade or tension pneumothorax, as in case of obstructive shock. So in all type of shock, the earliest manifestation is usually tachycardia, not explained with any other cause. There will be quiet tachypnea. Quiet tachypnea is seen in case of hypovolemic shock as well as distributive shock. But in case of cardiogenic shock, as there is associated pulmonary edema, so there will be tachypnea along with increased work of breathing. In case of hypovolemic shock, there will be normal pulse pressure. The blood pressure could be hypotension. The blood pressure could be normal or decreased depending on the stage of shock. In distributive shock, there is peripheral vasodilatation, and there is large gap between systolic as well as systolic and diastolic blood pressure. That is, there will be wide pulse pressure. So on examination, there will be bonding peripheral pulses, and the blood pressure could be normal, or the patient could be hypotensive depending on stage of shock, whether compensated stage or decompensated stage. In cardiogenic shock, there is narrow pulse pressure. Delayed capillary refill time is seen in case of hypovolemic shock as well as cardiogenic shock and obstructive shock. But in case of distributive shock, and especially in case of in distributive shock, if the patient is in warm type of shock, in that case the capillary refill time will be decreased, and that is known as flash capillary refill time. Whereas in other type of shock, there will be delayed capillary refill time. Altered mental status and oliguria is seen in all cases of shock with advanced stage. In case of distributive shock, there will be warm and flushed extremities, whereas there will be cold extremities and wide toe to core temperature gap in hypovolemic as well as cardiogenic shock. There will be favorable response to fluid in case of hypovolemic shock as well as distributive shock, whereas there could be adverse response to fluid challenge in case of cardiogenic shock as the patient is already having signs and symptoms of fluid overload. Now coming on to the how preload, afterload and cardiac contractility changes in different type of shock. In case of hypovolemic shock, the primary pathology is there is fluid deficit, which could be either due to GI losses or it could be due to hemorrhage. So there will be decreased preload. The cardiac contractility remains normal, and due to compensatory mechanism, there is redistribution of blood from skin and GI tract. So there is vasoconstriction at skin level. So the capillary refill time will be increased. And as there is peripheral vasoconstriction, so there will be increase in afterload in case of hypovolemic shock. Mixed venous saturation, which is a marker of increased oxygen extraction at the tissue level, will be low in case of hypovolemic shock. In case of cardiogenic shock, the primary pathology is decreased cardiac contractility. Due to decreased cardiac contractility, the ejection fraction is decreased. There will be increase in end diastolic volume. There will be associated increase in preload. Due to compensatory mechanism, there will be increase in afterload. Capillary refill time will be increased in case of cardiogenic shock, and mixed venous saturation will again be low in case of cardiogenic shock. In case of distributive shock, the primary pathology is abnormal vasomotor tone. So there is abnormal vasodilatation. Due to abnormal vasodilatation, there is decrease in systemic vascular resistance. As afterload is dependent on systemic vascular resistance, so there will be decreased afterload in case of distributive shock. There is compensatory increase in cardiac contractility. Preload will be decreased due to peripheral pooling of blood. Capillary refill time will be decreased due to flash capillary refill time. Mixed venous saturation is high as there is peripheral pooling, so there is increased oxygen extraction at the tissue level. In case of obstructive shock, there is mechanical obstruction to cardiac dilatation as well as contraction, such as seen in case of cardiac tamponade as well as tension pneumothorax. So there is increased preload, cardiac contractility is decreased. There is compensatory increase in systemic vascular resistance leading to increase in afterload. Capillary refill time will be increased in case of obstructive shock, and mixed venous saturation will be low. Now coming how to assess the patient of shock. So any patient we are suspecting shock, we have to go for pediatric assessment triangle. In pediatric assessment triangle, we look for appearance, work of breathing and circulation. In appearance, we have to look for reduced muscle tone, decreased mental status, weak cry, decreased responsiveness, purposeless or vacant stare, failure of child to recognize or respond to his or her parent, and there is poor response to painful stimuli. So these are all markers of decreased CNS perfusion, and this means that patient is in advanced stage of shock. In breathing, we have to look whether the patient is having effortless tachypnea, that is tachypnea not associated with increased work of breathing, or whether the patient is having increased work of breathing. Effortless tachypnea is seen in case of hypovolemic shock as well as anaphylactic shock, and in case of distributive shock. Increased work of breathing is seen in case of cardiogenic shock as there is pulmonary edema. In case of septic shock, there could be increased work of breathing if there is associated pneumonia in case of septic shock. Increased work of breathing could also be seen in case of tension pneumothorax as the lung is already compromised. In circulation, we have to look for cold extremities. In shock, advanced stages of shock, there will be cold extremities with increased toe to core temperature gap. There will be mottled appearance, acrocyanosis and pallor. So by these features, we could rapidly assess the patient, whether the patient is in shock or not. We have to look for skin findings and capillary refill time. Capillary refill time increase in case of cold shock. It will be decreased in case of warm shock. Blood pressure is not required to define shock in pediatric patients. It could be normal, low, or it could be even high. Mental status, if the patient is presenting with altered level of consciousness, that means there is decreased cerebral perfusion and it is an ominous sign. Urine output, which is a marker of internal organ perfusion. So if there is decreased urine output, that means the patient is in advanced stages of shock. Now coming, how do we recognize the severity of shock? In early stages of shock, that is compensated stage, the patient will be restless, anxious, and will be irritable. In advanced stages, the patient could be unconscious, the patient could be listless, the patient could have apathy and confusion. In the initial stages of shock, the patient will have slightly increased heart rate, whereas in advanced cases, there would be significant tachycardia. In the initial stages, the patient will have normal or slightly decreased blood pressure, but the blood pressure would be above the hypotensive cutoff. Whereas in advanced cases, the patient will be hypotensive. There will be pale and cold skin in early compensated stage of shock, whereas cold clammy skin will be present in later stages, decompensated stage. There will be slightly increased respiratory rate in cases of compensated stage, whereas rapid breathing or slow, shallow, irregular respiration could be seen in case of decompensated stage of shock. There will be slightly decreased body temperature in early stages, whereas there will be significant toe-to-toe temperature gap in case of decompensated stage of shock. In advanced stages, there could be decreased cerebral perfusion, which ultimately leads to confusion and incorrect slurred speech. There could be decreased or absent reflexes. The pupils could be dilated, and the patient could be unconscious. And if the patient is not managed properly in this stage, the patient will ultimately lead to multi-organ dysfunction and irreversible stage of shock and ultimately to death. Now, how do we define if the patient is having hypotension? So for this, we look for 5th percentile BP cutoff, and for rough estimate, we could have BP cutoff according to age. In case of term units, 0 to 28 days, if the BP is less than 60 millimeter of mercury, or for 1 month to 12 months of age, if the BP is less than 70 millimeter of mercury. In age group of 1 to 10 years, if the BP is less than 70 millimeter of mercury plus 2 into age in years, that is, if a 5-year child is there, if the BP is less than 80 millimeter of mercury, that means the patient is in hypotension. In 10 years and older child, if the BP is less than 90 millimeter of mercury, that means the patient is in hypotensive state. This we have already discussed. If the patient is having cold shock, the pulse pressure would be narrow. In case of warm shock, there will be bounding peripheral pulses. There will be wide pulse pressure. Now, coming on to the management, in general management, in all cases of shock, if the patient is presenting with shock, we start with 100% oxygen and we titrate according to SpO2, according to requirement of the patient. Fluid is administered in all cases of shock, and the amount of fluid and the rate of flow of fluid is dependent on type of shock. Fluid is to be given judiciously, especially in case of cardiogenic shock, as the patient might be in fluid overload. We have to manage both hypo as well as hyperthermia. We have to correct any metabolic abnormalities. The patient is having hypoglycemia or hyperglycemia, both has to be managed. The blood glucose should be managed below 180 milligram per deciliter. And if there is any electrolyte abnormalities, that has to be taken care of. Depending on the cause if the patient is suspected to have septic shock, antibiotics should be administered within 1 hour. If the patient is not responding to fluid alone, we have to start inotropic support. And mechanical ventilation help by decreasing the work of breathing. Along with that, it also help in redistribution of blood. Management, general management, as with all cases of emergency, we look for airway, breathing and circulation. In airway, if the patient is unconscious or if the patient is not able to protect his airway, we have to intubate the patient. In breathing, we should start with 100% oxygen and titrate oxygen, the 5O2 depending on the saturation of the patient. Circulation, we have to rapidly establish IV access, and if we could not gain IV access within 90 seconds, we should go for intraosseous cannulation without wasting any time. We have to monitor the patient by looking for capillary refill time and frequent blood pressure monitoring along with other vital signs. Laboratory studies that has to be done, we have to do ABG to look for PaO2, whether the patient is having sign hypoxia, hypercarbia, or if the patient is having any metabolic or respiratory abnormalities. In shock patient, we are expecting the patient is having metabolic acidosis. We have to look for lactate, and serial lactate monitoring is to be done to look for improvement with perfusion, to look for improvement with fluid administration. We have to do blood sugar. We have to avoid both hypo as well as hyperglycemia. We have to send electrolyte, and we have to correct any electrolyte abnormalities. CBC is to be done to look for any anemia, thrombocytopenia. PTA, PTINR for any coagulation abnormalities. Type and cross matching has to be done if we have to go for any blood transfusion. Urine blood cultures or any site-specific culture if required to look for both organism as well as susceptibility of organism to different antibiotics. So if we could not access intravenous access within 90 seconds, we should directly go for intraosseous access. If the patient is in cardiac arrest or decompensated shock and we could not rapidly achieve IV access, we should not wait for more than 90 seconds. And once we have gained venous access, we could easily remove intraosseous access later on. The equipments that are required for putting intraosseous access include alcohol swabs, povidone iodine, 18 gauge needle with trocar, 5 ml syringe, 20 ml syringe, and infusion fluids. If the patient is conscious, we could apply local anesthesia if required. We have to give analgesia, anesthesia, and sedation if the patient is fighting. Procedure, we have to identify the appropriate size for intraosseous access. It could be either proximal tibia. In proximal tibia, anteromedial surface 2 to 3 centimeter below the tuberosity. In case of distal tibia, if the patient proximal to the medial malleolus, or we could go for distal femur in midline 2 to 3 centimeter above the external condyle. So procedure, coming on to the procedure, we have to prepare the skin by initially cleaning the site with alcohol, followed by povidone iodine, and again followed by alcohol. After that, we insert the needle through the skin, and by screwing motion perpendicular to the bone, we go into the bone marrow cavity and slightly away from the epiphyseal plate. Once we have a feeling of decreased resistance, which is known as feeling of give away, if there is this feeling, that means that we have reached the bone marrow cavity. We could confirm that we have reached the bone marrow cavity either by aspirating the bone marrow through a 5 ml syringe, or we could give a 5 ml normal saline bolus. If it is going free flow and there is no swelling after that, that means that we have reached the bone marrow cavity. Then we should secure the needle and start the infusion by manually with 20 ml syringe. Now coming on to the volume expansion, we have to replace both deficit fluid as well as maintenance fluid. Deficit fluid is the fluid lost prior to the medical care. It could be either replaced by crystalloid fluid, which is preferred fluid, or if it is not responding to crystalloid alone, or if we are suspecting third space losses, we could go for colloid fluids. Crystalloid fluids include ringer lactate, normal saline or half normal saline. In colloids, could be either albumin, dextran, or potash starch. In maintenance fluid, we have to replace the insensible water loss. It is calculated by Holiday-Sager method. According to Holiday-Sager method, for initial 10 kg of body weight, we have to give 100 ml per kg of fluid. For next 10 kg, that is for 10 to 20 kg, we have to give 50 ml per kg of body fluid. And for any additional weight after 20 kg, we have to give 20 ml per kg of body weight. So if the patient is of 22 kg, for initial 10 kg, we will give 1000 ml of fluid. For next 50 kg, we will give 500 ml of fluid. And for next 2 kg, we will give 40 ml of fluid. So the total daily requirement of fluid will be 1540 ml. Now, the amount of fluid that is to be given in different type of shock. In hypovolemic shock, we have to administer 20 ml per kg of fluid boluses over 5 to 10 minutes, and this could be repeated as per requirement. In case the patient is presenting with severe diarrhea with severe dehydration, we could give fluid up to 100 ml per kg. This 100 ml per kg of fluid is further divided into 30 ml per kg and 70 ml per kg. If the child is less than 1 year of age, the initial 30 ml per kg of fluid is to be given in 1 hour, and the next 70 ml per kg of fluid is to be given in 5 hours. If the child is more than 1 year of age, the initial 30 ml per kg of fluid is to be given in half an hour, and then next 70 ml per kg of fluid is to be given in 2.5 hours. If the patient is presenting with hemorrhage and there is blood loss, so for every ml of blood loss, 3 ml of fluid is to be replaced. If the patient is presenting with shock, trauma, or burn, and the patient is not responding to fluid alone, we could consider for albumin, which is to be given as a plasma expander. In case of cardiogenic shock, the patient might present with fluid overload. So initially we have to assess for signs of any fluid overload, and if there is signs of any fluid overload, we should start with diuretics and vasodilators. If there is any signs of fluid deficit or the patient is dehydrated, we should give small liquids of fluid 5 to 10 ml per kg of fluid, which is to be given over 10 to 20 minutes. And during this fluid administration, we should monitor for any signs and symptoms of fluid overload, such as raised GVP or bilateral chest cramps and congestive hepatomegaly or pedal edema. In case of obstructive shock, we should go for definitive care. If the patient is having tension pneumothorax, we should go for needle decompression. If the patient is having pericardiocentesis, cardiac tamponade, we should go for pericardiocentesis. Now, if the patient is of septic shock, in septic shock, there is dictum of golden hour. That is, the earlier we start treating the shock, the better is the prognosis. We should give antibiotics within 1 hour. We should start with supplemental oxygen as per requirement and titrate according to saturation of the patient. We should rapidly establish IV access, and if we could not gain IV access, we should go for intraosseous access. We should administer fluid boluses of 20 ml per kg of isotonic saline, and fluids up to 60 ml per kg could be given until perfusion improves, or if the patient is showing any signs of fluid overload. We have to correct any hypoglycemia, or if any electrolyte abnormalities is present, such as hypocalcemia, we have to correct that. We should administer antibiotics within 1 hour, and we could measure serial lactate monitoring could be done to look for improvement in shock. In case of anaphylactic shocks, the drug of choice is adrenaline, which is to be given IM, and fluid should be given as per requirement. In neurogenic shock, 20 ml per kg of fluid boluses is to be given over 5 to 10 minutes. Special consideration is to be given in pediatric patient if they are presenting with severe acute malnutrition. So in case of patient presenting with severe acute malnutrition with shock, we should not give any rapid fluid boluses. The recommendation is that we should give 15 ml per kg of fluid which is to be given over 1 hour, and during this we should monitor the patient for any signs of fluid overload, and we should monitor for heart rate as well as respiratory rate. If the heart rate is increasing by more than 15 or the respiratory rate is increasing by more than 5 per minute, that means we should stop the fluid administration. But if the patient is having improvement in heart rate or as well as improvement in respiratory rate, then we could try for additional fluid bolus. The preferred fluid for SAM patient is either ringer lactate with 5% dextrose or N/2 saline with 5% dextrose. Now, the amount of fluid bolus that could be given in patient of septic shock depend on whether we have ICU care available with us or we do not have ICU care available. If we have ICU care available with us, we could give fluid up to 40 to 60 ml per kg with each bolus of 10 to 20 ml per kg. And this is to be given within 1 hour. If we do not have ICU care available with us and the patient is not having hypotension, then no fluid boluses is to be given in these patients. If the patient is having hypotension, then we could give 10 to 20 ml per kg of fluid bolus with maximum of 40 ml per kg of fluid bolus, which is to be given over 1 hour. Now coming on to the goals that we have to achieve within 1 hour as per American Academy of Pediatrics. We should monitor for both central and peripheral pulses, and both central as well as peripheral pulses should be strong and distal pulses should be equal to central pulses. We have to look for peripheral skin signs of improved peripheral skin perfusion, that is the periphery should be warm and the capillary refill time should be less than 2 seconds. We should look for mental status. The patient should have normal mental status. Urine output should be more than 1 ml per kg per hour. Blood pressure cutoff we have already discussed in previous slide. Subsequent ICU goals, we have to target for normal serum lactate level. The serum lactate level should be less than 2 millimole per liter. We have to target for mean arterial pressure. We have to restore and maintain normal perfusion pressure, which is defined as mean arterial pressure minus central venous pressure for that age. We have the central venous oxygen saturation should be maintained above 70%, and the cardiac index, which is equal to cardiac output divided by body surface area. The cardiac this should be maintained between 3.3 and 6 liter per minute per meter square. Now coming on to the inotropic support, that the initial choice for inotropic support in case of cold shock, which is a commoner type of shock. In cold shock, the preferred inotrope is epinephrine, and if epinephrine is not available at our center, then we could give dopamine. If the patient is presenting with warm shock, then the preferred agent is a vasopressor, because the vasopressor causes significant vasoconstriction, which ultimately lead to redistribution of blood. So the preferred vasopressor would be norepinephrine. Now coming on to the different inotropic support, we are giving adrenaline. Adrenaline it stimulates all adrenergic receptors, whether alpha 1, alpha 2, beta 1, beta 2, all receptors are activated, stimulated. So due to effect over beta 1 receptors, it causes increased cardiac contractility. It also causes increase in heart rate, and at higher doses, it leads to increase in systemic vascular resistance. So the preferred dose of adrenaline is between 0.1 to 0.3 microgram per kg per minute, because at these doses there will be increase in heart rate as well as cardiac contractility. as cardiac output is equal to stroke volume into heart rate. So due to increase in cardiac contractility, there will be increase in stroke volume, and due to increased heart rate and stroke volume, there will be increase in cardiac output. And there is also additional benefit of decreased systemic vascular resistance. So the adrenaline is preferred at lower doses, but we could go up to 1 microgram per kg per minute. But at higher doses, there is increase in systemic vascular resistance. So due to increased systemic vascular resistance, there is increase in afterload, as well as there is increased myocardial oxygen demand. So it is preferred that we go for lower doses of adrenaline up to 0.3 or up to 0.5 microgram per kg per minute. And if we require more inotropic support, then we could add any other inotrope as well. Now, how do we prepare adrenaline infusion? So adrenaline vial comes with doses. 1 ml of adrenaline ampule contains 1 milligram of adrenaline. So the amount of adrenaline that is to be dissolved is equal to weight in kg into 0.3. So this much milligram of adrenaline is to be dissolved in 50 ml of 5% dextrose or 10% dextrose or normal saline. When this infusion is run at the rate of 1 ml per hour, it corresponds to 0.1 microgram per kg per minute of adrenaline infusion. Now, coming on to the second inotrope, that is noradrenaline. Noradrenaline is a vasopressor agent, that is, it causes intense vasoconstriction. In case of warm shock, as there is abnormal vasodilatation, so we need any agent which causes intense vasoconstriction, so that there is redistribution of blood to more vital organs such as heart and brain. So noradrenaline is particularly helpful in case of warm shock, as it causes vasoconstriction as well as increase in systolic blood pressure as well as diastolic blood pressure. It also has some positive inotropic effect, and the dose is 0.05 to 1 microgram per kg per minute. Now coming on to the dopamine. Dopamine bonds both with dopaminergic as well as adrenergic receptors. Dose range up to 5 microgram per kg per minute. It is not beneficial at this dose. At this dose, it activates vasodilatation mainly in renal and mesenteric bed. The clinically significant dose is 5 to 15 microgram per kg per minute to be given in shock. At this dose, beta-1 effect predominates. And due to beta-1 effect, there is increase in cardiac contractility leading to increase in stroke volume. Along with that, there is increase in heart rate and there is increased systemic blood pressure. And there is minimal effect on diastolic blood pressure. Now, dopamine at higher doses, though causes increased vasoconstriction, but there is additional increase in myocardial oxygen demand. So, due to disproportionate vasoconstriction and increased myocardial oxygen demand, we generally prefer dopamine at a dose below 15 microgram per kg per minute. Dobutamine is again dobutamine has predominant effect over beta-1. So due to effect over beta-1, there is increase in cardiac contractility leading to increase in stroke volume. It has a small chronotropic effect, that is, it increases heart rate also, but that is less than dopamine. So the overall effect is increase in cardiac output and improved perfusion, but BP may not increase substantially with dobutamine alone. So it is particularly helpful in a patient with poor perfusion with high systemic vascular resistance due to vasoconstriction. So it is particularly helpful in patient of myocardial dysfunction, or if the patient is having persistent hypoperfusion despite achieving adequate intravascular volume and adequate mean arterial pressure. The dose for dobutamine is 5 to 20 microgram per kg per minute. Now, if the patient is not responding to fluid and is requiring vasoactive support, so in that cases, American Heart Association recommends that we should start stress dose corticosteroid. The stress dose corticosteroid means 50 milligram per meter square per stat dose followed by 50 milligram per meter square per kg per day divided into 4 divided doses. Now, indications for blood product transfusion. If the patient is having hemoglobin less than 7 gram per deciliter, we could transfuse packed red blood cells. If the patient is having any deranged coagulation profile, or if the patient is having any active bleeding, or if we are planning for any surgical or invasive procedure, and the patient is having deranged coagulation profile, we should go for fresh frozen plasma. Prophylactic platelet transfusion is to be done only if the platelet count is less than 10,000 and the patient is having less than 10,000 platelet count. If the patient is having significant risk of bleeding and the platelet count is less than 20,000, then we could go for platelet transfusion. Or if the patient is having any active bleeding, or if the patient is going for any surgery or any invasive procedure and the platelet count is less than 50,000, then we should transfuse the platelet in this patient. Now, the blood glucose level should be maintained below 180 milligram per deciliter, but we should also avoid any hypoglycemia. Antibiotics should be started within 1 hour, and once we have we have reversed the shock and the patient is having any signs of fluid overload, then we could give diuretics to reverse any fluid overload. Deep vein prophylaxis is not routinely recommended. We should give prophylaxis to prevent stress ulcers, and we should prefer for starting of early enteral nutrition in these patients. Now, how do we monitor the patient of septic shock, whether the patient is responding or not? We should look for pulses. We should look for capillary refill time. We should look for signs of dehydration. We should look for any signs of fluid overload if the patient is having pedal edema, or if the patient is having tachycardia with congestive hepatomegaly with raised jugular venous pressure, or bilateral clefts. That means the patient is in fluid overload. So we should monitor for these. We should look for toe to core temperature gap, respiratory pattern. The patient will, with metabolic acidosis, will have rapid breathing. We should look for urine output, which is a marker of internal organ perfusion. We should look for mental status. If the patient is having altered mental status, that means the patient is having ominous sign and the patient may land up into irreversible stage. We should look for biochemical markers, such as we should monitor for glucose, calcium levels, lactate, serial lactate monitoring is to be done to look for improvement in perfusion. Electrolyte levels, blood urea, creatinine, and liver enzymes should be done to look for any MOTS, multi-organ dysfunction. CBC as necessary. Now, take-home message from today's lecture would be we should recognize the patient in initial compensated stage, and we should try to manage the patient in initial stage, because once the patient had advanced to irreversible stage, then there is no benefit with any treatment. Fluid therapy is the mainstay of early treatment, and the majority of patients respond to fluid therapy alone, especially in case of hypovolemic shock and septic shock. Careful monitoring is to be done to assess for adequacy of fluid therapy. And for warm shock, the preferred agent is noradrenaline, and for cold shock, the preferred vasoactive agent is adrenaline. Now, thanks for all. Now, these are my references, and I thank for all the contributors to this lecture, and thank you. Now, is there any question? So, as for one question is there for cardiogenic shock, whether we prefer dopamine or dobutamine. So for cardiogenic shock, the dobutamine is preferred. Now we are going for second lecture, as there is no any further question. The second lecture will be taken by Dr. Vikas Agrawal from LLM Meerut on ARDS and its management. So I invite Dr. Vikas Agrawal to deliver his lecture.
Thank you, Doctor. Am I audible?
Yes, you are audible, sir.
And my slides are visible?
Yes, your slides are visible, sir.
Thank you, Dr. Neeraj. Good afternoon, everyone. I welcome all participants. This is the fourth day of your COVID PICU training. So after the first session, which was on how to manage shock in pediatric patient of COVID-19, now we are coming to the next dreaded complication, that is how to manage ARDS in COVID pneumonia. Because we know that ARDS, if not managed properly, is associated with very high mortality rate, even in best of the best nurseries, IPICUs. So what will be the learning goals? So before I begin, my sincere gratitude to all the contributors for this presentation. So learning goals for this presentation is: what is the definition of pediatric ARDS? How do you define severe COVID pneumonia in children? Lab evaluation of severe COVID-19, pharmacological treatment, then the respiratory support, indications for mechanical ventilation, and then lastly, what should be the ventilatory strategy for ARDS due to COVID-19. This is a very important slide which is depicting the stereotypical clinical course of COVID-19 complicated by ARDS. So as you know, so the clinical course of COVID-19 is divided into 4 phases, that is incubation period, early phase, pulmonary phase, and the recovery phase. So the incubation period, that is from the from the time of exposure of the virus till the onset of symptoms, is the incubation period, and you can see that the infectivity is also at peak during this time. So even before the onset of symptoms, such person who has been exposed to COVID-19 can act as a spreader to other people who comes in contact. So that is why the contact tracing was so important. Then after the onset of symptoms till 7 days of 7 days, it is considered as early phase. So this is the phase where the virus is multiplying. So this is the period where if you want to use any antiviral drug like remdesivir, if indicated, should be used in this phase. Similarly, like the cocktail regimes are available these days, so that should be where it is indicated, should be used in the early phase, right? Then after 7th day, there is a pulmonary phase, which are also known as inflammatory phase, where the inflammatory markers like C-reactive protein, ferritin, D-dimer, etc., they start rising exponentially. So this is the time where you should use anti-inflammatory drugs like steroids. So use of steroids in the early phase is not beneficial, rather it can cause harm. And similarly, using antiviral drugs later in the inflammatory phase is not useful. So that is why this slide has been placed here to make you understand that what is the stereotypical clinical course of COVID-19. Now coming to the definition of severe COVID-19. So pneumonia with any one of the following, that is cyanosis or saturation less than 90% with increased respiratory efforts in the form of grunting, severe retraction, or lethargy, somnolence, or seizure. Anything present with pneumonia is known as severe COVID pneumonia. A critical disease is a subset of severe disease, and it is defined as, apart from pneumonia, if there is presence of either ARDS or shock or multi-organ dysfunction syndrome, it is known as a critical disease. So the question arises that how common is severe COVID in children? Because in the first wave and the second wave, we have not seen much of COVID in the pediatric population. So here is a systematic review of 7480 pediatric patients with confirmed COVID-19. Out of these, 2% children develop severe disease in the form of dyspnea, central cyanosis, and hypoxemia, and only 0.7% were critical, developing ARDS, respiratory failure, and shock. So this number 0.7 might seem very little to us, but considering the huge population, pediatric population in our country, even this percentage will put enormous burden on the health infrastructure. So the preparation has to be done in advance before the third wave occurs in children. So when to suspect ARDS? If there is progressive tachypnea or dyspnea in a child suffering with pneumonia, or there is persistent tachycardia with diffuse crackles, or there is alteration in the mental status, there is confusion, or respiratory distress along with cyanosis, diaphoresis is there, then you may suspect that the patient is progressing towards ARDS. If there are alveolar infiltrates on chest imaging, which is consistent with the findings of ARDS, or there is declining oxygen saturation and the FiO2 requirement is increasing to maintain the target saturation, one must suspect that the ARDS is on the way to settle. Silent hypoxia or happy hypoxia, which is seen in adults, is usually not seen in pediatric population. Remember, cough, chest pain, wheeze, hemoptysis, fever are inconsistent finding of pediatric ARDS. Now coming to the for the definition of ARDS, what are the requirements? We need an X-ray, chest X-ray. We need certain parameters which we can derive from blood gas, like PaO2. SpO2 we can derive from the pulse oximeter. Other parameters we can obtain from the devices like FiO2 from the ventilator, and mean airway pressure again from the ventilator console. Then after deriving these parameters, we have to calculate certain values to make the to fulfill the definition of ARDS. One such value is PF ratio. What is PF ratio? PF ratio is the ratio of PaO2 divided by FiO2. So if this ratio is less than equal to 300, it is said that the patient is suffering from ARDS. Similarly, we have another index, that is SF ratio, that is the SpO2 divided by FiO2. And if it is less than equal to 264, it fulfills the definition of ARDS. Similarly, we have two index, oxygenation index and oxygenation saturation index. Oxygenation index is calculated by multiplying FiO2 with mean airway pressure into 100 divided by PaO2. And this oxygenation index is required to categorize ARDS into mild, moderate, severe, severe form. And OSI is oxygen saturation index, which can be calculated by multiplying FiO2 into MAP into 100 divided by SpO2. So always remember, you have to make a definition of ARDS before labeling a child as a case of ARDS. So coming to the definition of ARDS, so any child whose PF ratio is less than or equal to 300 or SF ratio is less than or equal to 264 fulfills the definition of ARDS along with the X-ray findings which are consistent with acute lung parenchymal disease. Now, what we exclude patients, those who acquire lung disease from the perinatal age, like haline membrane disease or bronchopulmonary dysplasia. We do not keep them in the definition of ARDS. Similarly, the timing of onset should be within 7 days of the clinical insult, and the edema should not be explained by cardiac failure or fluid overload. So as I've told you, oxygenation index is calculated to categorize ARDS into mild, moderate, severe. If oxygenation index is between 4 to 8, it is considered as mild ARDS. If it is between 8 to 16, it is considered as moderate ARDS. And if oxygenation index is more than 16, it is severe ARDS and carries very poor prognosis. So, who are at risk to develop ARDS? So, a patient who is on CPAP or BiPAP requiring FiO2 more than 40% to attain a saturation of 88 to 92%, the clinician must alert that this child probably may land up into ARDS. Similarly, if the oxygen flow requirement as per the age to maintain SpO2 88% or above is there, then that child is at risk to develop ARDS. So till less than 1 year of age, if the oxygen flow rate is requirement is 2 liters or more, then that child is at risk to develop ARDS. Between 1 to 5 years, if the oxygen flow rate requirement is 4 liters or above per minute, then that child is at risk to develop ARDS. Between 5 to 10 years of age, if the oxygen flow requirement is 6 liters per minute or more, that child is at risk to develop ARDS. And more than 10, if the flow rate requirement is 8 liters or above per minute, the child is at risk to develop ARDS. So these are all indicators that the clinician should keep in mind that which child is at risk to develop ARDS. Now, once you have made the diagnosis of ARDS in a child, how to manage such children? Such children are ideally managed in PICU. The laboratory investigations which are required are CBC, liver function test, KFT, inflammatory markers like CRP, D-dimer, ferritin, procalcitonin, blood gas, and X-ray chest. And these investigations may be repeated every 24 to 48 hours as per the clinical condition and requirement. Now, grading the lung disease on the basis of X-ray. According to this, we have divided each side of lung into 3 zones. The right lung into upper, middle, and the lower zone. And similarly, the left lung is divided into upper zone, middle zone, and the lower zone. So thus we have total of 6 zones. The lung findings, what we have to see on X-rays, peripheral opacities. These opacities are usually rounded in morphology, and the distribution is mainly in the lower lung. So how to grade the lung disease on the basis of X-ray? We say the lung disease is of mild variety if the opacities are present in only 1 to 2 zones. If the opacities are present in 3 to 4 lung zones, it is considered as moderate lung disease. And if more than 4 zones of lungs are involved, then we say it is a severe disease. Let's take an example to clarify this grading. Now, in this X-ray of chest, if we divide the lung field into 6 zones, we can see that both lower zones, the opacities are present in both lower zones, both middle zones, and is also present in the right upper zone. Relatively, a left upper zone is partially spared. So, because 5 zones are involved, that is, if the lung zones more than 4 are involved, we label it as a severe type of lung disease. I hope it is clear. Now coming to what is the role of HRCT in evaluation of ARDS. So oftenly the idea comes to our mind, or thought comes to our mind, that in our vicinity, the facility of HRCT is not available, or the patient has to be moved to a very distant place for HRCT. So remember, HRCT is not routinely required or indicated in COVID pneumonia. So what are the requirements? So indications for HRCT in COVID ARDS are: if you are have a high suspicion of COVID pneumonia, but RT-PCR is negative. In such case, you should go for HRCT chest. Or there is an unusual clinical course, or you have a suspicion of fungal pneumonia. In such cases, HRCT is required. Otherwise, for a case of ARDS, routine chest X-ray is sufficient. And the common findings on CT are ground glass opacities, also abbreviated as GGO, consolidation, it is the opacities are usually bilateral, peripheral in distribution, and mainly involves the lower lobes. The prerequisites for getting HRCT chest is that the patient should be hemodynamically stable and should not be on very high ventilatory settings. So if a patient is hemodynamically unstable or on very high ventilatory settings, such patient should not be moved to CT center. And also if the patient is on NIV or HFNC, in such scenario also HRCT should be delayed. Now, gas, ABG, when you get it done, it shows hypoxemia. Initially, it may be associated with respiratory alkalosis. Why respiratory alkalosis initially? Because of the tachypnea, there is washing out of carbon dioxide. And the alveolar arterial oxygenation gradient is elevated. Later on, there is development of hypercapnia, which is because of respiratory acidosis. If present, is an ominous sign and carries poor prognosis. Metabolic acidosis present, if present, is indicative of either sepsis, shock, or poor organ perfusion or hypoxia. Okay, so so you have to interpret ABG carefully under the clinical circumstances. So clinical monitoring along with serial ABG is important. So how to treat a case of severe COVID-19 in children? As such patient has to be admitted in PICU, cannot be managed in ward. The respiratory support has to be provided. We have to see whether the patient is a candidate for steroid plus minus remdesivir or not, depending upon in which phase the patient has come. Use of antibiotics has to be empirical, since it is a viral pneumonia, so antibiotics has to be used judiciously, and high-end antibiotics should not be used unless indicated. And the fluid therapy, you have to be gentler on the fluid therapy, because to avoid overload and pulmonary edema. So remdesivir should be used only in hospital settings. It is not recommended by DGCI. The only recommendation, if indicated, the dose is 3.5, between 3.5 to 40 kg weight. The dose is 5 milligram per kg on day 1. And from day to day 5, it is used in the dose of 2.5 milligram per kg. Beyond 40 kg, the dose is adult, like 200 milligram on day 1, followed by 100 milligram from day 2 to day 5. So 5 milligram per kg is given between a weight of 3.5 kg to 40 kg. Above 40 kg, the dose is similar as of adults. It should be used, as emphasized earlier, within 10 days of onset of symptoms, which has been beautifully depicted in the first slide, because that is the time of viral replication. In the inflammatory phase, there is no role of remdesivir. So contraindication of using remdesivir is if the ALT, AST is more than 5 times the normal, or if the creatinine clearance is less, or if the renal profile is deranged, that is in the form of creatinine and urea. Steroids, you should be used in inflammatory phase and not in the early phase. If you can use either dexamethasone or methylprednisolone, the dose of dexamethasone is 0.15 milligram per kg per dose. Maximum you can use 6 milligram in BD doses. Or if you are using methylprednisolone, the dose is 0.5 to 1 milligram per kg per dose BD. and the steroid has to be used depending upon the clinical assessment, and the duration of use is from 5 to 14 days. Coming to antimicrobials, since it is a viral disease, you have to use it judiciously. If indicated, you can use amoxicillin or co-amoxiclav or third generation cephalosporin if the co-bacterial infection is suspected. Higher antibiotics should be used only on the basis of culture reports or the clinical scenario. Respiratory support should be used depending upon the available option and the condition of the patient. If the patient is of moderate pneumonia, can be managed on NIVs like HFNO or CPAP. And invasive ventilation should be used in severe pneumonia or the patient is not manageable on non-invasive ventilation. The target saturation for moderate is more than 94%. Once stable, it is more than 90%. Rather, we say between 88 to 92% for the moderate, and for severe, even beyond 85%, we are comfortable. Remember that if we ventilate a patient in prone position, that improves oxygenation, but prone positioning ventilation is possible only in older children. So wherever it is possible, we should promote prone positioning. So management, so how what should be the target SpO2? The target SpO2 for mild ARDS is between 92 to 97%. We can give a trial of NIV. If it fails, then remember that we have to intubate and ventilate the child as early as possible. For moderate to severe ARDS, the target saturation is 88 to 92%. And in such patients, we have to intubate and put the child on mechanical ventilation. So this is the slide showing stepwise management of hypoxia in COVID pneumonia. So if the FiO2 requirement is between 24 to 44%, it is basically we are recapitulating how to manage COVID pneumonia. So if the FiO2 requirement is between 24 to 44%, to achieve the target saturation, and the flow rate is required between 1 to 6 liters, we can use nasal prongs. If the flow requirement is between 10 to 15 liters, or FiO2 requirement is of 60 to 95%, we can use non-rebreathing mask. If the work of breathing is high, the patient is exhausting, the target saturation is not achieved, higher FiO2 requirement is required, then we should put that child on an IV like high frequency nasal cannula. And if the patient is not tolerating NIV, is on the verge of exhaustion, or there is signs of failure of NIV, such patient should be intubated and put on mechanical ventilation. So the indications of intubation and mechanical ventilation severe COVID is severe respiratory distress with exhaustion, poor sensorium if the GCS is less than 8, or there is threatened airway where NIV cannot be used. The child should be intubated and taken on invasive ventilation. If the saturation is less than 85%, despite of the use of BiPAP, CPAP or HFNC, such patient should be intubated and taken on ventilatory support. In case of severe ARDS, again, the child should be intubated and taken on ventilatory support. If there is respiratory acidosis which is worsening despite of use of NIV, such patient should be taken on ventilatory support. Now coming to the mechanical ventilations. So you know that by and large in pediatric, we use two types of ventilator. Either they are pressure controlled or volume controlled. So pressure controlled means that the pressure is fixed, which is set by the physician or the pediatrician, and the volume is variable. While in volume ventilation, the volume is fixed. Like we know that for tidal volume, we have a gentle approach of 6 ml per kg. We set the tidal volume and the pressure is variable to deliver that tidal volume. There are phase variables like trigger, limit, cycling and baseline. So triggers are usually either flow trigger or a pressure trigger. The limit is either volume controlled or the pressure triggered. Limit. And the cycling is, they are usually the ventilators, they are time cycle, but can be flow cycle. And so once the time or the flow cycle is over, the values, they return to the baseline. Now coming to mechanical ventilation, after once you have selected the pressure control mode or the volume control mode, whichever the pediatrician is familiar with or comfortable, then you have to select the mode, that is either SIMV or assist control. So what is the difference of between SIMV and the assist control? In assist control, all the breaths are supported by the ventilator. For example, if you can see in the assist control mode diagram, the bold, that is all assisted by the ventilator. The dotted are whether the patient is taking those breaths spontaneously or not taking spontaneously. All are supported by the ventilator. Suppose you have set a ventilatory rate of 30 and the patient is breathing at a rate of 40. So 30 breaths will be supported by the ventilator, and the 10 breaths which were some spontaneous will also be supported by the ventilator in assist control mode. While in SIMV mode, only the breath rates which has been set, like in the previous example I told you, if you have set a ventilatory rate of 30, that will be supported by the ventilator in SIMV mode, while rest 10 breaths with the child is taking spontaneously, which is depicted by the dotted line, this will not be supported by the ventilator. As you can see the difference in the amplitude. So this is the basic difference between assist control mode and the SIMV mode. Now there is one more mode, that is SIMV plus pressure support. So what is done is that in SIMV pressure support mode, the spontaneous breaths which were not supported by the ventilator now providing pressure support. So this is again a very good mode where if you find that the work of breathing is increasing after putting the child on plain SIMV mode, so you can put that patient on SIMV with pressure support mode to have a smooth ventilation and to prevent atelectasis and better recruitment of the alveoli. So remember, there are various other modes in the ventilator. So never use CPAP or CPAP with pressure support ventilation as the initial mode. This is a weaning mode. So remember, only SIMV mode or assist control mode. Never use CPAP or any other mode as an initial mode. So coming to the settings, how you do the settings. So once you have selected the pressure or the volume control, then you select the as set the mode, assist control or SIMV. If you have selected volume control mode, you set the tidal volume of 6 ml per kg. Suppose the weight of the child was 10 kg, so you will set a tidal volume of 60 ml. And if you have selected pressure control mode, you will set a PEEP of 20 to 22 centimeter. The idea of setting PEEP is to see a decent rise of chest wall. If the chest wall is rising too high, you have to reduce the PEEP, and if the chest wall is not rising, you have to increase the PIP. And PEEP, so remember in ARDS, we have to start PEEP from higher side for the alveolar recruitment. So we start with 8 to 10 and we can go even up to 14, 15, 16 till the target saturation is achieved. So remember that the PEEP is on the higher side on the ventilatory settings in case of ARDS. Yes, it comes at the expense. There is high chances of pneumothorax, but still to achieve target saturation, we need higher PEEP in case of ARDS. FiO2, we can start with 100% saturation, and to achieve the target saturation, once it is achieved, then we start titrating, we start reducing it. Respiratory rate or the ventilatory rate has to be set as per the physiological age of the child, and the TI time is to be set as per the physiological range. Remember in ARDS, as we have told you that the IE ratio is usually 1:2 or 1:3, but in ARDS sometimes we also keep IE ratio of 1:1 or even reversal. Prefer using cuffed ET tubes in case of ARDS, because such patients are ventilated for a long time and we want to prevent the incidence of ventilator associated pneumonia and leakage. So how to modify the settings on the basis of the response? Suppose if you have put the child of ARDS on ventilatory settings, and after half an hour or 15-20 minutes you have got a gas done, and this gas is showing low PaO2 despite of high PEEP and 100% FiO2. So if you want to improve oxygenation further, so there are three ways. Either you can increase the PEEP, or you can increase the FiO2 if it is not 100% already, or you can increase the TI time, that is inspiratory time. So there are three parameters, either PEEP, TI time, or FiO2. And out of these three, the best is PEEP. And if the PCO2 is high rising, if there is hypercapnia, there are two ways you can wash out CO2. That is, you know that minute ventilation is the product of tidal volume into respiratory rate. So either you can increase the tidal volume or you can increase the respiratory rate. Since we want to be gentler on the tidal volume, so we can increase the respiratory rate to improve to CO2 elimination. I hope this is clear. So mechanical. So what you have to accept when the on mechanical ventilation when the child is of a case of ARDS, you have to accept high CO2 values till the pH level is above 7.2. So if the pH level is above 7.2, even the higher PCO2 level has to be accepted. This is acceptable. This is known as permissive hypercapnia. You have to ensure adequate sedation and analgesia the patient so that the patient tolerates mechanical ventilation. So midazolam infusion has to be there. We initiate at a dose of 1 to 2 microgram per kg per minute and titrate as per the need. And we also give fentanyl infusion, and we start from 0.5 and we can go to 2 mics per kg per hour, and we all can increase further also. We have to titrate the dose according to the desired effect. And if despite of sedation and analgesia, if the patient is not tolerating mechanical ventilation, then we have to also introduce neuromuscular blockade like vacuronium or norcuronium. So routinely it is not required. Consider only if sedation or analgesia is inadequate to achieve effective ventilation. So what are the indications of blood transfusion? So blood transfusion in case of ARDS, a child who is on ventilation should be done if the hemoglobin is less than 7 gram per deciliter. In this picture, you can see this patient is nursed in prone position and ventilated. And if the patient is unstable or in septic shock, then you can transfuse packed red blood cells even if the hemoglobin is up to 10. And prone ventilation, though it is difficult, must be tried because it improves oxygenation. So what monitoring you have to do after putting the child on mechanical ventilation, you have to monitor heart rate, respiratory rate, blood pressure, SpO2, consciousness, urine output. This all has to be recorded every 15 30 minutes or 45 minutes, every 2 hours, then later on every 2 hours. Then lab monitoring, you have to guess done ABG 1 to 2 times a day or on the SOS basis as per the requirement. There cannot be a blanket statement that you have to get it done once or twice or thrice. That you have to repeat according to the clinical scenario of the patient. Then X-ray chest again on the SOS basis. If you are suspecting pneumothorax or any deterioration in the patient's condition, then you have to get an X-ray chest done. Remember, if you are suspecting pneumothorax in the form of fall in saturation, poor chest rise, appearance of cyanosis, poor air entry on the side of pneumothorax, don't wait for the X-ray for the confirmation of pneumothorax. Put the needle, otherwise you will lose such patient. Inflammatory markers you have to get done every 24 to 48 hours or as per the clinical scenario and the need. So ventilatory monitoring, what you have to see, you have to look for the chest rise, you have to look for the retractions, you have to look for the plateau pressures. Plateau pressures tell you about the compliance of the lung. Then you have to look for the minute volume, alarm limits. So ventilation is it's a art and science, amalgamation of art and science, which you learn gradually once you start ventilating the patient and spend time. Avoid frequent circulate disconnection for suctioning. Ideally, inline suctioning should be used. Sedation adequacy has to be ensured, and holiday from sedation daily should be done for at least 1 hour to monitor the level of consciousness of the patient. Now let's take a case scenario that what we have understood till now, how much we have learned. Now this is 6-year-old child who is 15 kg, arrives in the emergency department. She was unwell for 7 days with fever, cough and progressive respiratory distress. So she is in pneumonia. She is a case of pneumonia. She is agitated. Her airway is clear. She is in severe respiratory distress. Uh, uh, on applying pulse oximeter, her saturation is 84% at 100% FiO2. The HFO has been applied at a flow of 30 liters, but still her saturation is 84%. So she is a case of severe pneumonia. If we calculate from this SF ratio, so SF ratio in this child will be 84 divided by 1. 100%, that is 1. So it will be 84. So less than SF ratio, less than 264 is the definition of ARDS. So definitely this child is a case of ARDS. Heart rate is 170, BP is 100 by 68, which is okay for this child. Peripheries are warm and the gas, pH is okay, PCO2 is 30 and PO2 is 50, little on the hypoxemia side. Okay. So what initial settings you will set? You will intubate this child. You will put this child on invasive ventilation. Suppose we have taken volume control mode. So tidal volume, how much you will set the tidal volume? This child is a 15 kg. So 15 into 6 will be 90. So 90 ml will be the tidal volume. PEEP, since there is hypoxemia and the child saturation is 84%, even on 100% of FiO2, we will start with high PEEP. We will keep respiratory ventilatory rate in the physiological range from 20 to 30. Since the PCO2 was 30, as you could see in the previous the ABG, the PCO2 is 35. So we don't want to keep ventilatory rate on the higher side. TI is 0.8 and FiO2. Once you have set PEEP on the higher side, so you can titrate FiO2 from 100% to the lower side. You have to provide good sedation, analgesia with or without muscle relaxant, and you have to keep a watch on plateau pressure. So you have to monitor the child and once the target saturation is achieved, you will start weaning the child. How you will wean the child? You will start decreasing the PEEP first because you are on the higher PEEP. Once the PEEP is comfortably on the lower side, and then you can decrease FiO2, etc. So this is the flow diagram, which is telling about the management summary of severe COVID pneumonia. So you have any child with pneumonia having any of these like cyanosis, saturation less than 90%, or having grunting, severe retractions, or letharginess, or having seizures or somnolence, has to be labeled as severe pneumonia and should be admitted in ICU or HDUs. Okay, you have to evaluate for sepsis, shock, or multi-organ dysfunctions. You have to put that child either on non-invasive ventilation or intubate and take on invasive ventilation depending upon the clinical scenario. You have to use with or without steroids, with or without remdesivir, depending upon in which phase the patient has arrived in the ICU. Then empirical use of antibiotics. You have to use interface accordingly. If you are using NIV and target saturation, depending upon the type of respiratory distress, and prone positioning, if possible, should be tried, and you have to be gentler on the fluid therapy. So what is the take home message? Focus on the basics. Don't try fancy things. Just focus on the basics. Steroids, remdesivir, low molecular weight is nothing, is not miraculous drugs. The right patient, the right time, the right management is the key for success. Ventilation is a blend of art and science, so you have to spend time with the patient and the machine to have a better understanding. Ventilate gently with low tidal volume. Aim for the acceptables, not for the normal blood gas, and communicate with the relatives, since the ARDS is associated with high mortality rate. So communication with the relatives and the parents is of utmost importance to avoid chaos later on. So these are the additional materials which are available on the sites. You can go through. My sincere thanks to the contributors once again, and sincere gratitude to all the participants for the patient listening. Thank you. Any questions, Dr. Shalin?
Thank you, Dr. Vikas. Uh, in the question in the chat box, Dr. Amit Singh is asking high PEEP versus moderate PEEP.
High PEEP, as I have told you, that high PEEP is required to improve oxygenation. In ARDS, basically the alveoli, they are atelectatic. So if you want to recruit the alveoli, you want to improve the gas exchange and improve oxygenation, we need high PEEP. Because unless the alveoli, they are recruitable, the oxygenation will not improve. So that is why we start with the high PEEP, and once the target saturation is achieved, then we start decreasing the PEEP. I hope I have answered the question.
Yes, yes. And I'm not able to see any other questions in the chat box. So
Okay.
thank you very much for the talk. And now Dr. Manisha Gupta is asking, what is the target SpO2 in severe ARDS?
In severe ARDS, basically the idea is to make such, initially we want the SpO2 has to be about 85%. But later on we want it to be 88 to 92% at least. So first target is to push SpO2 above 85%, and later on between 88 to 92% at least. And once the child starts improving, obviously we want to target normal saturation.
Okay. Thank you very much. So we are closing the pre-lunch sessions, and we will be meeting post-lunch at 2 p.m. again for the rest 3 lectures. Thank you very much.
Thank you.
A very good afternoon to all of you. Is my screen visible? Am I audible?
Yes, ma'am.
Okay. So for the post-lunch session, I'm going to start the topic, which is multi-system inflammatory syndrome in children, MISC. When to suspect and clinical features. So just a minute, I'm sorry, I just shared the wrong presentation. I'm just sharing it again. Is my screen visible now?
Ma'am, still previous presentation is seen.
It's a new presentation now I've shared. Is it visible?
Yes, ma'am. Yes, now it's.
So multi-system inflammatory syndrome in children. So I'm Dr. Shalini Tripathi. I am additional professor in Department of Pediatrics, King George's Medical University, Lucknow. And today in the next 1 hour, we are going to talk about this peculiar disease which is associated with the COVID-19 infection and mainly in children. So the learning objective of this session would be, when we are going to suspect MIS-C, what are the clinical features, how we are going to stepwise evaluate if a child comes, and what is the WHO diagnostic criteria for MIS-C, and how we are going to manage these cases. So what is multi-system inflammatory syndrome in children? MIS-C is a novel multi-system hyperinflammatory syndrome that follows exposure to COVID virus by about 2 to 4 weeks and mainly affects children and adolescents. And first reported cases, they came from United Kingdom in April 2020 and they presented typically as Kawasaki disease like illness, the surge of which followed that of COVID-19 by a month. So usually what happens when there is a peak of COVID epidemic, there is in a particular community, just around a gap of 1 month, we used to see these kind of patients of multi-system syndrome. How common is this condition? So if we see overall, it is not a very common condition. Other conditions like general causes of fever, other causes of fever, dengue fever, scrub typhus, they are much more common. But we have to suspect, especially because of the COVID which is occurring at this time. So of all the COVID-19 infection in children and adolescents, less than 1% is multi-system inflammatory syndrome. But if we see the patients hospitalized with COVID-19, so it makes around 10% of those proportions. So how does it happen? So the pathogenesis of this condition is incompletely understood, and it is diagnosed in children who had COVID infection previously and also diagnosed in the children who are having COVID active infection too. And the possible mechanism of infection which is proposed is it can be because of the immune dysregulation, antibody enhancement, and T-cell mediated damage or enhancement. So this is a diagram which is made by Dr. Satyen, and it tells very clearly about how this multi-system inflammatory syndrome affects the children. So in this diagram, the stage 1 is early infection. So stage 1 occurs in children which is mostly undetected, which is mostly asymptomatic. And then these viruses, they do the nasopharyngeal colonization. And after that, there is a stage 2, which is a pulmonary phase. And this phase is usually not there. The ARDS, the pneumonia is most of the time is skipped in children. Why it is skipped? Because of the particular receptor, the lack of ACE2 receptors, which are the main receptor of attachment of this virus in the pulmonary epithelium. So they are not in the children, they are less of them are there in the children. So the pulmonary phase is not there. And after that, what happens? This colonized virus, it leads to later on activation of the macrophages, which in turn activate many immunological cells like helper T cells, B cells, and all these cells. They produce inflammatory mediators like TNF beta, interleukin 12, C6, 1 beta, etc. And these inflammatory mediators, along with the antibodies, together they produce a cytokine storm and a hyperinflammatory state, which is a delayed inflammatory state with a gap of around 4 weeks after the acute COVID infection in the child. So then what happens then? The child has actually the manifestation which is affecting each and every system of the body. So if it is starting from above downwards, if it is happening from above downwards, it is like meningeal irritation, mucosal inflammation in the brain. So the child will complain of headache. There is pulmonary edema, consolidation, atelectasis in the lungs. In the heart, there is a ventricular dysfunction. There are coronary artery aneurysm. Because of that, the child presents in severe shock. And in the kidneys, the patient can have the AKI, acute kidney injury. And in the liver, there is pericholecystic edema. In the skin, there will be rash, which is a macular kind of rash, non-vesicular. And in the GIT, there is mesenteric lymphadenopathy, ileitis, colitis, ascites. So these are all the manifestation of multisystem inflammatory syndrome. So now coming to the pathogenesis of multisystem inflammatory syndrome. So as shown in the picture on the left hand side, if a child has got a low viral load, then what happens? There is a early interferon response is very high as compared to the antibodies and the interleukins produced, and which clears virus very rapidly and less of inflammation is there. But suppose the viral load is very high, then what happens? The inflammatory mediators are even higher, and the inflammatory mediators, they produce a kind of inflammation more in case of high viral load, and these children, they are more prone to develop these kind of syndrome. So this is a mechanism why not all the children and very particular children are having this particular syndrome. So then these are the clinical features, again from a beautiful diagram made from Dr. Satyen Lakshman. So this shows that the child has the features like a fever with myalgia. The child will present minimum of a fever of 3 days with the whole body ache, and conjunctivitis. The conjunctivitis will be non-purulent conjunctivitis, red eyes, lymphadenopathy, stomatitis will be there, cracked lips, and extremity swelling and erythema and skin peeling, just like the Kawasaki disease. Then in the GIT, the patient will have nausea, vomiting, abdominal pain, and diarrhea, and AST by ALT ratio will be increased. Then in the brain, the patient will be having meningismus, severe headache, and lethargy. And in the heart, the very particular, very peculiar about this is coronary artery aneurysms. The coronary artery aneurysms later on lead to hypotension. Also, the left ventricular ejection fraction is reduced. Because of that, the patient usually goes to shock. And all the cardiac markers like troponin T and proBNP, they are found raised. In the hematological markers, the patient will be having high ESR, CRP, ferritin, LDH, interleukins, fibrinogen, procalcitonin, and creatine phosphokinase and D dimers, they will be raised in this condition. In the lungs, the patient will be having hypoxemia, pulmonary infiltrates, and chest pain. And A very important diagnostic criteria which gives us a clue thinking about this condition is that the lymphopenia will be there and there will be leukocytosis. So the polymorphs will be more and the lymphocytes will be less, and the absolute lymphocyte count will be always less than 1000 per cubic centimeter. In the there is also a clue about in the electrolytes. Most of the many times we used to find hyponatremia, and if the kidney functions can also be deranged. These are the mucocutaneous manifestations which are seen here as in form of this is the red eyes, red BP eyes, non-purulent conjunctivitis, and the edema in the extremities, then red strawberry tongue, and the peripheral extremities, they are having the macular rash and also the cracked lips. So all these things, they should always point towards the Kawasaki, towards the MIS-C, that is multisystem inflammatory syndrome. So this was a large series which is published from USA in March 2020, which tells us also about the clinical spectrum, how these children can present. And in that series, they found out that the children, they basically belong to three categories. So the first category was the hyperinflammation, that all the markers are increased with multiple organs involved, usually more than 6 organ systems involved in 50% of the patients, and cytokine storm was there, and almost all the patients, they had GI and cardiovascular involvement, and 98% were COVID antibody positive, and they seen that these children, they had a mortality of 0.5%. Second group, it consists of 30% children, and they had mainly the presentation of ARDS, that is respiratory system, and myocarditis. And very surprisingly, because initially we thought that all the MIS-C patients, because they are presenting mainly after 2 to 4 weeks after the COVID infection, so they will be antibody positive. But it can happen even in the antigen positive patients. So these patients, this subset of patients, in 84% they found the antigen positive also, the PCR were positive. And they had, that is the ARDS and myocarditis patients, they had the highest mortality in the tune of 5%. The class 3, that is third subset, which is typical Kawasaki or atypical Kawasaki disease like patients, they were usually 6 years and above, and in 63% they found they were antibody positive, and in 34% they found both antigen and antibody positive. Although because they presented as Kawasaki, they had evidence of coronary artery aneurysm in the echo, but it is a very reassuring thing that the mortality in this group was 0%. So this gives us a clue that how the patients of MIS-C are going to behave in our country also. So then we have a curiosity to know that is there any difference between MIS-C and the COVID-19 infection, because MIS-C also affects pulmonary system and COVID also. So it was seen in the same series that if we see system wise, so GI system was more commonly involved in MIS-C as compared to severe COVID. The mucocutaneous manifestations were usually not there in severe COVID, they were mainly in MIS-C. Coronary artery aneurysms and LV dysfunction were more in MIS-C as compared to severe COVID. And respiratory involvement without cardiovascular involvement, that is ARDS, atelectasis, pneumonia, severe pneumonia, they were more in cases of severe COVID and not in multisystem inflammatory syndrome. If we see the neutrophil lymphocyte ratio, this ratio is higher. The neutrophil polymorphonuclear leukocytosis is more in favor of MIS-C, and CRP levels are high in both, but they are quite high, above usually 100 and in patients of MIS-C. Then this is a slide which tells about the difference between the multisystem inflammatory syndrome and Kawasaki disease. So the first difference is that age. Kawasaki disease usually presents at 5 years and above. It rarely present in a child of 1 to 5 years. But MIS-C can present in an infant, in an adolescent. It has got a broader age range. And the more prominent GI and the neurological symptoms in MIS-C, Kawasaki will hardly have any GI or neurological manifestations. Mucocutaneous manifestations may be absent in MIS-C, but Kawasaki, to make a diagnosis, you have to fulfill those 5 criteria in which the mucocutaneous lymph node involvement is to be must. And MIS-C more frequently presents in shock as compared to Kawasaki and more likely to have cardiac dysfunctions. If we see the blood test, then MIS-C patient will have thrombocytopenia, lower absolute lymphocyte count, that is the total absolute lymphocyte count less than 1000, and higher CRP levels as compared to Kawasaki. So if we are suspecting some patient of multi-system inflammatory syndrome and externally he is not behaving as Kawasaki but fulfilling the criteria, then it is must to be to do an echo in such patient, because even if there is no rash, there is no lymph node involvement, there is no conjunctivitis, but then also the coronary artery aneurysms, they should also always be searched in a patient suspected of MIS-C. So then now we are going to see that how we are going to investigate these patients. So whenever we have a patient, especially when there is a peak of COVID and then some weeks have passed, and then you have a patient, a child who is having a fever of 38 degrees centigrade or more of 3 days and above, and certain clinical features like rash, conjunctivitis, shock, multi-system involvement, suggestive of MIS-C, an epidemiological link of COVID infection, like in the family, in the past few months, there is a history of COVID, or in the child itself, then what will we do? That we have to see that the patient is well or the patient is sick. So if the patient is having shock or any life-threatening condition, the patient is very sick, we have to do all the tests all together. And we have to treat the patient simultaneously for MIS-C, and simultaneously if we are thinking about some infection, that also, because initially if the patient is very low, we cannot rule out the severe sepsis or any other infection also. But if the patient is stable and the clinical clues are towards MIS-C, then always the other alternative diagnosis for fever like dengue, typhus, which are very common in this particular season, they should be ruled out. And after ruling out those common infections, we will make and treat for multi-system syndrome. If we have not ruled out and straight away jump to this diagnosis, then many of the patients, the cause would be something else and we will be treating him as missing. So that will not be correct, because it is very important to rule out the common infections before, if the patient is stable. So suppose the patient was very, very sick. So we have to, in the evaluation, do the tests which are called as tier 1 and tier 2 tests all together. Because the patient is very sick, we don't have any time. If the patient is not sick, then we will do first tier 1 test, and if these tests are positive, then we will go for the further evaluation. So what is a tier 1 test? So in this, we have to do the complete blood count, the metabolic profile of the patient, like liver function test, the renal function test, ABG. If ABG is not possible, then serum sodium would do, because we are looking for hyponatremia, blood glucose levels, serum albumin levels. We are looking for hypoalbuminemia, because it is one of the criteria I am coming into it. Then we are looking from the inflammatory markers, CRP and or ESR, and COVID antibodies and PCR. Both have to be done if we are having a patient clinically suspected of this condition. So what is a tier 1 positive screen? So first we have to have the inflammatory markers increase, that is CRP high of more than 5 and ESR high of more than 40 in 1 hour, and at least one of the following, in which first is absolute lymphocyte count less than 1000 or platelet count less than 1.5 lakhs, or serum sodium less than 135 MEq per liter, neutrophilia, or hypoalbuminemia. So if you have anyone along with the CRP and ESR raised, your tier 1 test is positive. Then we have to go for the tier 2 test, in which we have to do the detailed cardiac evaluation. For that, we are going to do the ECG, echo, and the cardiac markers like proBNP and troponin T. And inflammatory markers, whatever is available at your place, you have to do the procalcitonin, prothrombin, APTT, D-dimer, fibrinogen, LDH, triglyceride, cytokine panel if available, and blood smear. So what we are looking for all these tests, and then we will call ki abnormal. So for pro-BNP, although the absolute cutoff values for pediatric population is not very well established, but for BNP, the levels more than 400 picogram per ml. In the echo, what we are looking for in the echo. So it is very important to tell the cardiologist that what do you want to look for. So you want to look for LV ejection fraction, coronary artery size and dilatations, because you are looking for the aneurysms, valvular dysfunction and pericardial effusion, and electrical conduction abnormalities. So LV ejection fraction was found in around 20 to 55% of the patients of MIS-C. The ejection fractions are reduced of around less than 35%. And coronary artery aneurysm, when we call it a coronary artery aneurysm, if we have the size of the coronary artery for that particular age and sex in between 2 to 2.5 Z scores. So you have the Z score tables available online, and the app is also available. For that, we should look for the, if the cutoff is more than 2.5 Z score, it is called as coronary artery aneurysm. And if the coronary, yes, and it was found in around 20% of these children. And D-dimer was found, D-dimer more than 2 milligram per deciliter is said to be positive. Fibrinogen more than 400 milligram per deciliter. And in the peripheral smear, you can have cystocytes and Burr cells. And for the D-dimer, the values, if they are more than 5 times of the normal, they are taken as abnormal. So now I am coming to the WHO diagnostic criteria for MIS-C. The first is age should be 0 to 19 years, fever of 38 degrees centigrade of 3 days and above, multi-system involvement. So what is a multi-system involvement? So multi-system involvement means any 2 of these 5 points is there in the patient. So what are these 5 points? First is rash, bilateral, non-purulent conjunctivitis or mucocutaneous inflammation in mucocutaneous inflammation. Second is shock. Third is myocardial dysfunction, pericarditis, valvulitis or coronary artery abnormalities. And fourth is evidence of coagulopathy, abnormal PT, APTT and D-dimer. Then acute GI problems like diarrhea, vomiting, abdominal pain. So any 2, if they are present, we will call it a multi-system involvement. Then there should be evidence of inflammation. That is very, very important. We have to document ESR and CRP or procalcitonin high. Then the exclusion of other diagnoses. That is a very important thing, that you have straight away jumped on the diagnosis without thinking of sepsis, viral infection, typhus, dengue. Then you may be many times not correct. So you have to really think about that, the alternative diagnosis in this. And if the things are, all these things are negative, then only this diagnosis will be entertained. And the epidemiological link with the COVID virus, either in terms of the serology or the PCR or antigen or likely contact with the COVID patient, is also sufficient to make a diagnosis. So all 6 criteria must be present to call a patient multi-system syndrome. So we have seen that there is no single diagnostic test. You have to look for the patient as a whole, and there's no one thing which can just prove that it is a patient of MIS-C. Now I'm coming to the management of these patients. We have made the diagnosis now and we are going to manage this patient. How we are going to do that? So there are three arms in the management. First, we are going to do the management of the hyperinflammatory state with the help of the immunomodulators like IVIG, corticosteroid, and very rarely anti-interleukin agent, anakinra. And the second arm is the procoagulant state. If there is thrombosis, we have to manage that with the help of the antiplatelet drugs, aspirin, anticoagulants, low molecular weight heparin, and of course the supportive care. So this is a algorithm which is taken from Ministry of Health and Family Welfare, and this tells that any patient, any child who is hospitalized with MIS, we have to look for the serious signs like if there is evidence of shock, coronary artery involvement, multi-system disease of life-threatening condition. So if the life-threatening condition is present, we have to immediately start the anti-inflammatory therapy by giving methylprednisolone in a dose of 1 to 2 milligram per kg per day with IVIG of 2 gram per kg over 1 to 2 days. Plus, because the patient is so sick and at that point of time you cannot very straight away remove the diagnosis of infection. So may start treating the infections by starting an optimum antibiotic as per your protocols. So suppose the patient was not sick. So only fever is there, otherwise there is no shock. The patient is maintaining saturations. So you have a sufficient time to rule out the tropical infections first. And if the infections are diagnosed, you are going to treat that. And actually it's not missing. But suppose the patient has no infections and then all the 6 criteria fulfilled, then for continuing fever we have to give anti-inflammatory medications like methylprednisolone, or anyone has to be given because this is a stable patient. So anyone is good enough, like methylprednisolone in 1 to 2 mg per kg per day, or IVIG 2 gram per kg over 1 to 2 days can be given. In these first subset of patient, when the patient was very critical, the Indian Academy of Pediatrics algorithm says to give a higher dose of, straight away to give a higher dose of methylprednisolone, which is 10 to 30 mg per kg per day. However, in this guideline, first we have to give the dose, and if the patient is showing no improvement or worsening of symptoms, then we have to repeat high dose of steroid, that is methylprednisolone of 10 to 30 milligram per kg per day, and repeat IVIG also. And this we have to continue for 3 to 5 days. And if the patient is unresponsive to this treatment also, we may consider high dose anakinra in a dose of 2 to 10 milligram per kg per dose, maximum 100 milligram per dose subcutaneous, 6 to 12 hourly. The availability in India, this drug is available, although I do not have any experience of giving this drug. Then how long we are going to give this methylprednisolone or steroid? So this depends on the inflammatory markers. So we have to taper steroid, we have to shift to the oral steroid 2 mg per kg per day, and taper steroid over 2 to 3 weeks while monitoring the inflammatory markers, and as they are normal, we will stop it. Then aspirin. What is the indication of aspirin? So you have a patient of MSC and the indications are either you are having thrombocytosis or there is evidence of coronary artery aneurysm Z scores more than 2.5. And the aspirin has to be added in all these cases. And the dose of aspirin is 3 to 5 milligram per kg per day with a maximum dose of 81 milligram per day. And a very important point that if the platelet count is less than 80,000 or active bleeding, aspirin is contraindicated. In case the patient is having coronary artery aneurysm and the Z scores are more than 10, and that is called as a giant coronary aneurysm, or there is a documented thrombosis, or the ejection fraction is less than 35%. These are the three indications of giving enoxaparin to the patient in a dose of 1 milligram per kg twice daily subcutaneously, and the monitoring which has to be done for giving the low molecular weight heparin is we have to monitor factor 10A activity levels. Although this factor 10A level is not very routinely available test, and this factor 10A level has to be maintained between 0.5 to 1. Important thing to note is that for the children with cardiac involvement, if the heart is involved, initially the ejection fraction was low. Then later on also we need to document the echo, and that repeat echo should be done at 7 to 14 days, then second at 4 to 16 weeks, and after 1 year if the initial echo was normal. So we have to document at least 3 more echoes if the first echo was abnormal, and ECG also if the first ECG was abnormal. So duration of therapy immunomodulators, we have to check the levels of them and need to taper the immunomodulators as the levels go down. Then serial cardiac monitoring has to be done. Aspirin minimum 4 weeks have to be continued, although it has to be continued till the platelet count becomes all right and the coronary artery size normalize. For enoxaparin, and we have to give minimum 2 weeks after discharge, but if there is a giant coronary aneurysm, then indefinitely it has to be given very long. And for the thrombosis, if there is thrombosis in the patient, then at least 3 months, and then also pending resolution of the thrombus, the enoxaparin has to be given. For cardiac dysfunction, we have to give the supportive care to maintain the hemodynamic stability, ensuring adequate systemic perfusion, the serial echocardiographic assessment of the cardiac function and proBNP and property levels. And if the patient is having severe LV dysfunction with ejection fractions less than 65%, they are treated with IV diuretics, ionotropic agent like milrinone, dopamine, and dobutamine. Then supportive care. So management of the shock, management of the respiratory failure, management of the multi-organ dysfunction, and antibiotic therapy and gastroprotection, they are all already told in the lectures. So they have to, of course, accompany, and they are a very, very important part of the management of a patient with MIS-C. So what is the outcome? Everything is told now. So usually in the series which are published, it is shown that the MIS-C patient, they have a favorable outcome, and around with the mortality rates of around 1 to 2%. Although most of the patients, they require intensive care and immunomodulatory therapies, they were given most of the time. Steroid is given in India because of the no availability of IVIG, and the nature and frequency of long-term complication is not known because the long-term follow-up data is going on and it's not available. So the take-home message of this lecture is that multi-system inflammatory syndrome in children is not common. It is not a very common condition, although we should know about it and we should suspect. When it is there, you have a clue in front of you, you should try to search for it and think of the common conditions for the fever first. Investigate judiciously if the high index of suspicion for MIS-C is present, and provide good supportive care and ensure judicious use of medication, especially steroids, and the outcome is usually favorable. Thank you very much, and my sincere thanks to all the contributors of this lecture. Thank you.
should I start sharing my screen, Dr. Shalini?
Yes, yes, please share. So now I welcome Dr. Sandhya Chauhan. For the next lecture, I welcome Dr. Sandhya Chauhan from SRMS Bareilly, and she will be talking about PICU management, hand hygiene, general care of patients, prevention of PrEP.
Thank you, Dr. Shalini.
Yes, please start, Dr. Sandhya.
Okay. Good afternoon, Dr. Chandrakanta ma'am and all the participants. So, in this lecture, I'll be talking about the general care of a child in pediatric intensive care unit, and our learning goals are going to be to learn the importance of supportive care in pediatric intensive care unit, to learn the components of general care of a critically ill child and how to provide that general care. Okay. So, when we talk about general care of a child in pediatric intensive care unit, basically we tend to talk about the early identification of critically sick signs and symptoms in the child, the severity assessment and resuscitation of that critically sick patient. And our focus of attention is primarily on the precipitating disorder. Okay, this is what we all do. But one thing about which we must be very aware and very conscious is that intensive care setting in itself is a very hostile and dangerous environment. So, on one hand, where our focus definitely should be providing the supportive care for the primary illness and to the severity related to it, on the other hand, we should not forget the basics of routine supportive and preventive care in pediatric intensive care unit. Now, this routine care, this is standard across the wide spectrum of presenting pathologies. Like you would have admitted a patient, you would have mechanically ventilated a child for a lung pathology, or you would have admitted somebody, a patient who is suffering from acute kidney injury, or somebody would be having life-threatening MISC. But the basic care bundle, the preventive and the supportive care in intensive care unit remains the same for every patient, and it has to be followed for each and every patient. Okay. Okay. So next, just a minute. I'll just change my slide. Some problem is coming. Okay. So, once we are talking of supportive care in pediatric intensive care unit, we are talking about three things. First is monitoring, second is prevention of nosocomial infections, and third is ongoing assessment and support. Once we are talking of monitoring, here we are talking of monitoring of the aspects of patient related to the primary pathology. That is the physiological indices, whether the patient is responding to your treatment or not, what are the trends, whether the patient is improving or deteriorating, and to raise alarms. This all has been dealt earlier. The second component is prevention of nosocomial infections. Now, there is a bundle of maneuvers which are practiced in every ICU to prevent this, and hand hygiene is the most important component of this bundle, and this we will be discussing in the later part of this lecture. The third, which we are discussing now, is regarding the ongoing assessment and support. Now, what is this? Apart from the basic disease pathology and monitoring its course, this ongoing assessment and support, this deals with other aspects of patient care, which if neglected will not only make the treatment of the basic pathology difficult and complicated, but will also make the treatment costly, intensive care units stay longer, and even add substantially to the mortality of the critically sick patients. Now, these multiple aspects, they can be remembered very easily by a simple mnemonic, and that is fast, hugs, bits. So, what every participant, every listener here can do is, even while listening to this lecture, you can prepare a checklist with the help of this mnemonic, and you can use this checklist on your daily rounds, as well as you can train your staff working in the intensive care unit to use this mnemonic, to use this checklist at the start of every shift, and this will help you immensely to keep a track of the key aspects of the general care of the critically sick patients. Now let us see what are the components of this mnemonic. So F stands for feeding, A stands for analgesia, S is sedation, T is thromboembolic prophylaxis, H is head of bed elevation, U is stress ulcer prevention, G stands for glucose control, S is spontaneous breathing trial, B is bowel regime, I is indwelling catheter removal, and D is de-escalation of antibiotics. We will see each one of these components one by one, but just a word, the spontaneous breathing trial, this has already been dealt in your lecture on a mechanical ventilation. So this we will not be discussing here, rest we will take one by one. Okay, so we will start with feeding, F for feeding. Okay, so several RCTs have shown that early feeding, this reduces the incidence of mortality, morbidity in ICUs by improving wound healing, by decreasing the loss due to metabolic stress response, and by improving GI function and integrity. Not only does this help in improving the nutritional status of the sick patient, it also helps to reduce the complications and the length of stay of the patient in PICU. So next question is, how much calories should be given? Now remember, in the acute phase of illness, this is not decided by RDA, that is recommended daily allowance. This caloric goal is decided by REE, that is resting energy expenditure. And the energy intake provided, whatever energy intake you plan to give to your patient, it should not exceed this REE value. Now there are certain formulas available online to calculate this REE, or in short I can just tell you that if we just restrict ourselves to a target between providing a calorie target between 27 to 58 kilocalories per kg per day, this will provide the energy intake according to REE in your critically sick child. The protein goal should be to restrict ourselves to 1.5 gram per kg per day. So I'll repeat, calorie should be restricted between 27 to 58 kilocalories per kg per day, and protein to 1.5 gram per kg per day. Now remember that you will have to increase the calorie requirement if the patient is having fever or burns, or is a patient having severe sepsis, or is a patient of trauma or having some activity. Okay, so what are the modes of feeding? So there are two modes that we use, enteral feeding and parenteral feeding. Now enteral feeding, where GI tract is directly used to deliver the nutrients and calories either orally or through NGOG tube, this is superior and the preferred one as compared to parenteral feeding. In parenteral feeding we deliver the nutrients directly into a vein. So enteral feeding is always preferred as compared to parenteral feeding, for obvious reasons. As you can see here, enteral feeding is physiological, has a trophic effect on gut mucosa, it prevents bacterial translocation and thereby decreases the incidence of sepsis. Is obviously cheap, simple, easy to administer, very easily you can ask your nursing staff to give this in the wards, in the ICUs, is associated with very few metabolic complications, and that's why all these points make it the preferable route. It has its set of disadvantages in the form of like NG tube, if it gets displaced, there can be risk of aspiration in your patient, there can be the risk of feed intolerance in your patient. But we resort to parenteral feeding only if there are contraindications present to enteral feeding. And what are the contraindications? Suppose you have admitted a patient who is having GI bleed, or the pathology has led to gut ischemia, or is a case of intestinal perforation or intestinal obstruction. Only in these conditions do we resort to parenteral feeding, because it has a lot of disadvantages, like it is non-physiological, is expensive, requires venous access, and thereby it increases the risk of sepsis. It requires frequent monitoring, and a lot of metabolic complications are associated with this. So how do we go ahead? Now we have decided the route, and how do we go ahead with feeding our patient? So the first step would be that you assess your patient for the presence of any contraindication of enteral feed that I have already told. Okay. Second, you look for bowel sounds. If no contraindication present, bowel sounds are present in your patient, you can start enteral feeding, keeping in check to keep the head end of the patient elevated to now again there are two modes of enteral feeding also. One is post pyloric feeding, second is nasogastric feeding. Now what decides that which feeding that we choose? The factors that decide are the risk factors for aspiration. So you will have to assess your patient for the presence of the risk factors for aspiration, like severe respiratory distress or recurrent vomiting. You have admitted a patient of recurrent vomiting, or the patient is having gastroesophageal reflux with history of aspiration, or the pathology per se has led to delayed gastric emptying. If these risk factors are present, you will resort to post pyloric feeding, either nasojejunal or nasoduodenal. If not, then you will resort to nasogastric feeding. Now, if you go ahead with nasogastric feeding, it is normally given in the form of bolus feeding. How do you start with this bolus feeding? So normally it is started with 25% of the target volume 2 to 4 hourly. Now what does this mean? Suppose there is a 10 kg weight child and you have decided that you are going to give 500 ml volume to fulfill his calorie needs. Now what you will do is, you will take out the 25% of this target 500 ml volume. Your target volume is 500 ml. So you will take out 25% of this target volume, which will come somewhere around like 120 or 125 ml. Now this 120 ml has to be divided into volumes which can be given 2 to 4 hourly. So suppose you decide that you are going to give the feeds 4 hourly, so you will be giving 6 feeds in 24 hours, 4 hourly, 6 feeds in 24 hours. So 120 ml will be divided by 6, you will get 20 ml. Now you will start with 20 ml 4 hourly feeds. If the patient is tolerating 2 to 3 such feeds, then you can plan for feed advancement and increase in the feed. Again, this is done at a rate of 25% increment over the start volume. So your start volume was 20 ml. So again a 25% increment will the next volume will come to be somewhere around 25 ml. So your after 2 to 3 feeds, if your patient is tolerating, you will go ahead with 25 ml volume. Again you will give 2 to 3 such feeds. Again if your patient is tolerating, again you will increase suppose to 30 ml to 35 ml, and this you will go on doing till the target volume of 500 ml in 24 hours is achieved. Similarly, in continuous feeding, what you will do, the start rate would be 1 to 2 ml per kg per hour. Again we will take the example of that 10 kg weight child. So I will be giving somewhere around 10 to 20 ml per hour. The maximum volume that we can give is 25 ml per hour in continuous feeding. Now again if your patient is tolerating, you have evaluated at 2 to 8 hourly intervals, you evaluate whether if your patient is tolerating, you can go on increasing at a rate of 1 to 2 ml per kg at 2 to 8 hourly intervals, till the target volume is achieved, which in less than 1 year child would be 5 ml per kg per hour, and in more than 1 year it would be somewhere between 5 to 20 ml per kg per hour. This is how we go ahead. Okay. Now once you are planning for feed advancement, one thing that you have to check is the pre-feed gastric residual volume. Now your patient would be having NG or OG tube. So what you have to do is, before you are increasing that feed, suppose you at 8 am you gave the last feed, and at 12 noon you have decided that now I am going to increase the feed volume. At 12 noon, before increasing the feed volume, what you will do is you will try to aspirate with the help of a 10 ml syringe, okay, what is there in the residual volume in the stomach. Suppose the residual volume that you aspirated at 12 noon was somewhere around, suppose the previous feed that you had given was 20 ml and what you aspirated was 15 ml. That means you have aspirated more than half of the previous feed volume. The next feed has to be put on hold. You cannot give the next feed. In higher volume feeds, if the gastric residual volume is more than 150 ml or more than 5 ml per kg, you will hold the next feed. You can give prokinetics to the patient in the form of metoclopramide or domperidone at a dose of 0.2 milligram per kg per dose. Still, if your patient is not responding, you can resort to smaller volume frequent feeds like 20 ml 4 hourly can be changed to 10 ml 2 hourly or 5 ml hourly feeds. The composition of the feeds should be such as to meet the needs of the critically ill child, which is up to 6 months baby, it is breast milk or express breast milk or formula feed. In children between 1 to 10 years, it is milk based feeds. Other feeds like dal and porridge also can be given. If you want to increase the caloric density, you can fortify the feeds given with the help of MCT oil or sugar or puffed rice. Take care for the supplementation of vitamins and minerals that has to be done in recommended daily allowance. Either you can give IV or orally. You can even take the help of a dietitian. Once the acute phase of illness is over, that is by 7th to 10th day of illness, you'll have to increase the caloric delivery by more than 50% from the increase from the present value in order to avoid underfeeding and thereby ensuing malnutrition in that patient. Okay. So this much about feeding. Next we'll go ahead with sedation and analgesia. Now, critically ill patients, they often require complex medical procedures in your ICU, frequent invasive testings, thus necessitating the provision of adequate analgesia and sedation in order to decrease not only pain but also the stress response. Always remember, these agents have to be used judiciously, intermittently, and with frequent monitoring of patients, because where under sedation will lead to stress with long term consequences, over sedation will lead to the need for prolonged respiratory support and prolonged ICU stay. That nobody wants. Okay. Analgesia and sedation, they are normally preferred over neuromuscular blockade because they are quickly reversible and allow for neurological monitoring. Okay. While selecting the agents for sedation, select such agents which have minimal effect on the vital parameters, especially the blood pressure. So the drugs that we prefer is short-acting benzodiazepines like midazolam in a dose of 0.1 milligram per kg. This is the bolus dose, and it is followed by infusion at a rate between 1 to 10 microgram per kg per minute. You start from 1, and depending upon the need, you can go up to 10 microgram per kg per minute infusion. For analgesia, fentanyl is the drug. The dose is 1 microgram per kg, followed by again 1 to 5 microgram per kg per hour infusion, depending upon the requirement. For pediatric ARDS, these agents, again I will repeat, they should be used in their minimal possible dose for the maximum desirable effect in the minimal dose. Okay. If sedatives are not completely effective, you can go ahead with neuromuscular blocking agents. The agents that we use is vecuronium, 0.15 milligram per kg is the bolus dose, followed by 15 to 25 microgram per kg per minute. Okay. In moderate to severe ARDS, neuromuscular blocking agents, they improve to tolerance to mechanical ventilation. Normally, you will put these patients on mechanical ventilation. So, you can use these neuromuscular blocking agents. They will help to improve the tolerance to mechanical ventilation by eliminating ventilator patient dysentery. And they also help in optimizing oxygen delivery by facilitating gas exchange. But again the same thing, their use has its own limitations in the form of profound muscle weakness. So, again they should be used at minimal possible dose, along with observing a daily 1 hour neuromuscular blockade holiday. You have to stop the neuromuscular blockade infusion, agent infusion for at least 1 hour every day for monitoring the clinical movement and development of critical illness polyneuropathy. Okay. Third is blood glucose control. In critically ill patients, again blood glucose abnormality, especially hyperglycemia, is also common. Why? Because it's a stress hormone response, or you'll be using additional medications like steroids, or exogenous dextrose administration would be given to your patients. Both the duration of hyperglycemia and the index of variability of the glucose levels, especially the peak glucose level, they are independently associated with mortality. By increasing the need of inotropic agents or mechanical ventilation, they increase the risk of infection also. Normally all the ICUs, they follow the protocol of testing blood glucose level at the time of admission. If normal, then you continue its BGL monitoring at 12-hourly interval. Any abnormal reading is followed by more frequent monitoring at the rate of 2 to 4 hourly interval. Now, what is the aim? To maintain blood glucose level less than 150 milligram per deciliter. But Again remember, aggressive attempts of lowering blood glucose level or keeping a tighter blood glucose control can lead to hypoglycemia, which is equally deleterious. So your aim should be maintaining a moderate for a moderate glycemic control. Any level more than 180 milligram per deciliter, the first step should be reduce the glucose infusion rates that you are using. If the patient not responding, definitely go ahead with insulin infusion. Okay. Now is pressure source. Common in PICU, the incidence is 26%. Common sites are occipital region, nose, chin, neck, heel, sacrum. The risk factors are if you put your patient on mechanical ventilation, HFO, hypotension, your patient is having hypotension, malnourished child, malnutrition is there, sensory loss, dependent edema, central line in the neck, length of stay in ICU is more than 96 hours. All these are the risk factors for pressure sores. How can you prevent it? By regularly examining the skin. You'll have to train your nursing staff for doing this. Regularly examine the skin. Frequently change the position of the patient every 2 to 4 hourly, provide adequate nutrition, keep the sheets dry and wrinkle free, and you can also use, as shown in the photograph, pressure mattresses. Okay, before I show you the photograph, this is a theoretical explaining the stages of pressure sores. Stage 1 is where the patient is having intact skin with non-blanchable redness. Management is protective dressing. Stage 2 is shallow open ulcer with red pink wound. Management is clean the wound with saline water and then apply moist dressing. Stage 3 is full thickness tissue loss with visible subcutaneous fat. Stage 4 is full thickness tissue loss with exposed muscle and bone. So here, if no necrosis is present, you clean the wound and apply moist absorbent dressing. If necrosis is present, definitely you will perform the debridement and then you will manage accordingly. Unstageable, there is full thickness tissue loss with base of the ulcer covered with slough or eschar. And there can be patients who will present with suspected deep injury, like they will be presenting with purple maroon localized area of discolored intact skin or blood filled blister. I will just show you the photographs. This is stage 1, non-blanchable erythema of intact skin. This is stage 2, where there is skin loss with exposed dermis. Here there is full thickness skin loss with subcutaneous fat visible. Here full thickness skin loss with underlying bone visible. This is the unstageable one where you cannot make out exactly how deep the ulcer is. It is covered with eschar or slough. Okay. Next we will talk about eye care. Now the ocular surface, our ocular surface is normally protected by our ability to produce tears, to blink, to close eyes with rest or sleep. Whatever mechanisms you are using for the benefit of your patient in pediatric ICU is going to compromise all these mechanisms. Just we can talk about certain things like you are using oxygen mask, oxygen, you are giving oxygen to your patient with the help of a mask, or you are using a CPAP. Now these gas flows, they have an effect, drying effect on the corneal surface. If you have sedated your patient, it reduces the blink reflex. If you are using muscle relaxants, it decreases the ability of your patient to close eyes, leading to lack of thalamus. If your patient has already suffered a neurological insult, it will further reduce the protective mechanism of the eyes. And all these things will lead to abnormalities of cornea and conjunctiva, leading to exposure keratitis, corneal ulceration, infection. And you can see them in quarter of patients, it's very common. What you can do is use lubricating ointments, artificial tears to keep cornea and conjunctiva wet, 1 drop every 6 hourly for both the eyes, each eye. If the eyelids are not fully closed, as shown in the photograph, you can use for protective eye taping. It's very effective in preventing corneal erosion. And when evidences of infection are present, definitely you will use antibiotic eye drops. Oral hygiene. Now again the same thing, whatever mechanisms maneuvers you are doing for the benefit of your patient will lead to compromise in the oral hygiene, like you are using sedation, or you are practicing fluid restriction in your patient, or you have put your patient nil orally, or you are using certain drugs that may exacerbate xerostomia. So all these things will decrease the normal saliva production and will compromise the oral hygiene. They will predispose to the oral colonization of drug resistant organisms, which form a very important source of ventilator associated pneumonia. Therefore, regular cleaning of oral cavities, especially in the intubated kids, is very important. Antiseptic solution like chlorhexidine you can use for this purpose. While cleaning, ensure that the dislodged plaques and secretions are not aspirated, and for that practice to keep the head end of the patient elevated. Endotracheal tube cuff should be inflated. Use as far as possible closed suction maneuvers. Okay. NHS-GGC pediatric clinical guidelines have been formulated to help you in this purpose, and they will just tell you how to go ahead, like you ensure that first the head end of the patient is at least 30 degrees elevated, wash and dry your hands, don disposable gloves, and assess mouth using several assessment tools are available online. Any you can use for assessing the status of the mouth. And then for the management per se of the oral hygiene, you can divide your patients into 3 age groups. First is neonates and infants less than 1 year with no teeth. Here our whole aim is to keep the mucosa moistened, and this is practiced every 2 to 4 hourly. So what we do is wrap a swab moistened with sterile water or saline around gloved finger and wipe the gums and mucosa with swab to moisten the mouth, and then apply yellow soft paraffin to lips. So this way you can keep the oral mucosa moistened, and this you have to do every 2 to 4 hourly. The second age group is comprised of infant and children between 1 to 3 years with teeth. So this 2 to 4 hourly practice of keeping the oral mucosa moistened, this has to be done. Along with that, what you do is you add one more thing, that is brushing of the teeth 12 hourly with small soft headed toothbrush and smear of fluoride toothpaste. Okay. The third group comprises of children more than 1 to 3 years with teeth. More than 3 years with teeth. So here 2 to 4 hourly procedure of keeping the oral mucosa moistened, this has to be done. 12 hourly brushing of the teeth has to be done. And the third component which is added is after tooth brushing, 30 minutes after tooth brushing, apply 1% chlorhexidine gluconate gel to the oral mucosa, teeth and gums with the help of a foam stick, and then do not rinse or moisten the mouth with water following this. So these 3 things can be done. Okay. Next is stress ulcer prophylaxis. Now, children suffering with hypovolemia or decreased cardiac output or intense pro-inflammatory cytokine release, they are normally predisposed to acute gastric ulcers due to decreased mucosal blood flow or decreased GI motility. And this forms a very important risk factor for upper GI bleeding, especially in the presence of thrombocytopenia, coagulopathy, organ failure, use of high pressures in mechanical ventilation, shock, prolonged surgery, and the use of steroid in that patient. But still, routine prophylaxis is not advised because literature suggests that this may increase the incidence of nosocomial infections. So what you can do is be cautious, observe for the volume and the color of the nasogastric aspirates. In the increase of volume or the change of the color from colorless to suppose it's reddish or brownish, this is the indication for GI bleeding, and definitely now you have to start using drugs. You can use ranitidine, sucralfate, or PPIs like pantoprazole. Thromboembolic prophylaxis. Now, venous thromboembolism is increasingly being recognized in children. The risk factors like secondary to illness per se, or age less than 1 year or more than 14 years, or recent surgeries, or complex medical conditions like malignancy or chronic cardiac or renal disease, or prolonged hospitalization, or inherited or acquired thrombophilia. Central venous catheter is the most common risk factor for this. What you can do is strict monitoring of the clinical signs and symptoms of VTE should be done in children. Since most pediatric VTEs are catheter related, they can be located either in the upper venous system or in the lower venous system. In the upper venous system, they will give rise to swelling, pain, discoloration in upper extremity. In the lower venous system, you can find abdominal, inguinal or leg pain, swelling, bluish purple discoloration in lower extremity. If suspected, Doppler venous ultrasound is the commonest modality to go ahead with to diagnose this. Standard unfractionated heparin or low molecular weight heparin prophylaxis is not routinely advised, but since we are talking of COVID-19 and MISC, here it definitely has an indication if the patient is having thrombosis or D-dimer values are more than 5 times upper limit of normal, or the patient has been diagnosed to be having giant aneurysm with an absolute coronary diameter of more than 8 millimeter, or coronary aneurysm score is more than 10 Z score, or left ventricular ejection fraction is less than 30%, you can use low molecular weight heparin, that is enoxaparin. Contraindications are marked thrombocytopenia, that is platelet count of less than 25,000 per microliter, hypofibrinogenemia, that is fibrinogen activity of less than 100 milligram per deciliter, end-stage renal disease, if the patient is of end-stage renal disease or he has suffered a recent major bleeding, you cannot use this drug. Once you started using, duration can be at least 2 weeks until at least 2 weeks after discharge from hospital. Longer duration can be used for patients with coronary aneurysm score of more than 10, or the patient is having documented thrombosis. So, for 3 months pending thrombus resolution you can use it, or if the patient is a case of ongoing moderate to severe LV dysfunction, you can use it indefinitely. The doses in neonate, it is 2 milligram per kg twice daily subcutaneously. In 1 month old child, it is 1.5 milligram per kg twice daily subcutaneously. In 2 months to 17 years, it is 1 milligram per kg twice daily subcutaneously. Remove the central venous line associated with VT as soon as possible. Ensure follow-up ultrasound to screen for extension of VT. You have done the first ultrasound, diagnosed it, started the treatment. Now you will have to go ahead with follow-up ultrasounds also to screen for extension, for the improvement or extension of the VT. Other procedures like early mobilization, physiotherapy, use of compression devices like stockings also can be done. Another drug which can be used is aspirin in cases of thrombosis or coronary aneurysm score of more than 2.5 Z score. Dose is 3 milligram per kg per day to 5 milligram per kg per day. Duration is until normalization of platelet count and confirmed normal coronary arteries at more than 4 weeks after diagnosis. Contraindications are active bleeding, significant bleeding risk, and a platelet count of less than 80,000 per microliter. Next is care of lines. So, there are certain lines that we put in the patient in ICU like intravenous line, central line, chest tubes, PD catheters. All these lines, they form a very important source of nosocomial infections, and therefore they should be observed very carefully. We will start with IV cannula, which should be, you have to train your nursing staff to examine it at least once per shift for phlebitis. They have to observe it while the cannula site, while they are giving bolus injections, or the IV flow rates are being checked, or when the solution containers are being changed. We have a visual infusion phlebitis scale. I'll just show you for the objective assessment and intervention in these cases, and it is here. In score 0, the site appears healthy, no signs of phlebitis, and you just have to observe the cannula. In score 1, one of the following is present, that is slight pain or slight redness is present. These are the possible first signs of phlebitis. You observe the cannula. In score 2, 2 of the following are evident. Either pain at the IV site plus swelling, or swelling plus erythema, or pain plus erythema would be present. This is the early stage of phlebitis. Remove the cannula immediately, change the site. In score 3, all the signs, pain, induration, erythema would be present. This is intermediate stage of phlebitis. Remove the cannula, change the site, and consider treatment in the form of limb elevation, using an anti-inflammatory analgesic like ibuprofen, making the patient wear compression stockings. 4, all signs are evident and extensive, pain, induration, erythema plus palpable venous cord. This is either the advanced stage of phlebitis, or we can say this is the beginning of thrombophlebitis. Remove the cannula, change the site, consider treatment like limb elevation, anti-inflammatory analgesic, wearing compression stockings. The 4th thing that you can add here is using a thrombophobe ointment, local application at the site. This ointment has benzyl nicotinate plus heparin. It not only dissolves the clot present superficially near the skin, but also relieves pain and inflammation by increasing the blood flow. In score 5, all are present, plus your patient will develop fever. This is the established phase of thrombophlebitis. Remove the cannula, change the site, consider previous treatment, and also initiate antibiotics. Central venous line, they have to be monitored regularly for displacement, bleeding, patency, infection, or for hematoma formation at the site. Remove as soon as no longer needed, or your patient develops fever with no obvious foci. Chest drains should be assessed periodically for movement of fluid column, amount and nature of drainage, displacement, breath sounds, and subcutaneous emphysema. PD catheter, peritoneal dialysis catheter, you have to monitor the patency of the dialysis catheter and the flow rate regularly. Remove as early as possible after completion of the peritoneal dialysis, and never forget to send the PD fluid and catheter for culture. Now, critical illness in itself, followed by intubation, mechanical ventilation, supine position of the patient, they can lead to deleterious effect on the lungs due to decreased cough reflex, decreased mucociliary clearance, sequestration of secretions, decrease in the lung compliance, etc. Here, chest physiotherapy plays a very important role in restoring lung health by increasing the drainage of secretions, improving ventilation perfusion matching, decreasing the work of breathing, and increasing functional residual capacity. So, you can use this as shown in the photograph. This can be achieved by using percussions or vibrations in the various positions of the patient. Now, practice of prone position in the ventilated children. This has been seen to increase oxygenation in early stages of ARDS by increasing functional residual capacity, increase in ventilation perfusion matching, by enabling drainage of the secretions, and by improving lymphatic drainage. So, the indications are it can be used in severe ARDS or children with severe COVID or in non-intubated children. Its effectiveness is still being investigated in moderate cases. If you happen to plan to use this, there are 6 positions. It begins by lying in prone position, then lying on your right side, then sitting up, then lying on your left side, then semi-proning, and then complete proning position. Every position has to be practiced on a flat bed for 30 minutes to 2 hours. At the completion of the 6 steps, again the cycle can be repeated. So, the key messages were: holistic care is needed for a critically ill child. You have to practice that. It's very simple. All the aspects can be remembered very easily with the help of a checklist that you can form by using this mnemonic: fast, hug, spit. Practice using minimal sedation in your patients. Try to early extubate your patient to improve the outcome. Nutritional support is equally important for early recovery. Physiotherapy done regularly not only helps to prevent sores but also improves the lung health, and always follow the dictum: first do no harm. These are the suggested references. These are the skills that we have just acquired. Next, we will talk about just quickly about the asepsis, how to maintain asepsis in the pediatric intensive care unit. So, the learning goals would be that we have to know what is healthcare associated infections, how to maintain strict asepsis in your ward and minimize common HAIs, the importance of hand hygiene, and prevention of ventilator associated pneumonia. Healthcare associated infections have been defined by CDC as any clinical infection, localized or systemic, that was not present at the time of admission. This is a major cause of mortality and morbidity in PICUs. Nearly 1/3 of critically ill patients, they suffer with this, and there are 3 common HAIs: bloodstream infections, VAP, and catheter associated UTI. VAP is ventilator associated pneumonia. Risk factors are age less than 1 year, prolonged stay in the ICU, most important risk factor, severity of illness at admission, prolonged use of sedation, use of broad spectrum antibiotics, pre-existing medical conditions, and use of invasive devices, very important source of nosocomial infections. Can we reduce this? Yes, by a 4-pronged approach of standard precautions, use of personal protective equipment, safe injection practices, practicing respiratory or cough etiquette, and most important is hand hygiene. Here there are 2 photographs that you can see. You can download it from internet and place it in your hand washing area. First is depicting hand wash, second is hand rub. So, hand wash, you can use soap or any hand wash having chlorhexidine and alcohol. There are around 11 steps. At least 1 minute should be devoted in following these 11 steps for a complete proper hand wash. Similarly, in hand rub, there are 8 steps. At least 30 seconds have to be devoted for this. You can use 0.5% chlorhexidine with 70% ethanol. Now, this chart is showing the 5 moments of hand hygiene. Now, all of us are in a practice of doing a proper hand wash before we enter the intensive care unit. But this chart tells us that after we enter the intensive care unit, suppose you are having a 10-bedded PICU or a 5-bedded PICU. On every bed, you have to practice this 5 moment of hand hygiene. What is that? Before patient contact, either hand hygiene or hand wash or hand rub, anything has to be done. After, you have already done it before you enter the PICU, but before visiting, suppose this is the first bed, do it. Second is, suppose you want to examine the patient, before that task you again do it. Then suppose there is a urobag lying down there and you want to examine it, the volume of urine in it. After body fluid exposure is again you do a hand wash. After the patient contact, your patient contact is over, again you do it. You're examining the files and all of the patient, and then after contact with the patient's surroundings, once you leave that bed, again you do it. And these 5-prong approach has to be practiced at every bed. If you're really serious about preventing HAIs, this has to be done. Then PPEs, gowns, gloves and masks. These are clothing or devices donned for safety or protection while performing hazardous patient activity. Everybody should know proper donning and doffing, especially doffing, that is more notorious for contamination. Respiratory etiquette or cough hygiene, covering one's mouth while coughing, not using hand but using the upper arm. Disposing of tissues and following hand hygiene practices after touching respiratory secretion. Safe injection practices in the form of cleaning with alcohol swab. The site should be clean with it. In the practice of using single dose vials or single use needles. We can also display posters and distribute it to the attendants about minimizing visits and other relevant cares, like before entering, remove your slippers and shoes. There can be a poster regarding that. Remove your ornaments, wash your hands, rub your hands before touching anything. Don't sit on the bed, don't touch anything in the ICU. All the things displaying, the poster should be there in order to display all this. If you are allowing patients inside the ICU, they should be donned with proper and adequate PPE. Proper disposal of biomedical waste, again a very important component. Disinfection and sterilization of intensive care unit and instruments should be done. Definitely you would be practicing it. Maintain the proper record. When did you do it? When the next sterilization is required? Everything should be recorded properly. Time to time culture audit of admitted patients should be done. Again it should be recorded. You keep a file where all the records are placed. Send culture from not only from the patient or the patient area, but also from the walls, ceilings, suction pipe, other areas during regular surveillance. And most important, use the antibiotics rationally, very important. Prevention of bloodstream infections, for that we can use central lines made of Teflon or polyurethane using minimum number of ports. Insertion should be done under aseptic precautions like scrubbing up to elbow, use of universal precaution, use of drapes over patient, and practicing skin antisepsis with 2% chlorhexidine or 10% povidone iodine. Use sterile gauze or transparent semi-permeable dressing. Do not use antiseptic ointment at the site of insertion. IV fluid administration sets, make it a habit to change it every 72 to 96 hours. Disposable pressure transducers used for CVP or ABG monitoring, change it every 72 to 96 hours. How to prevent UDI? Catheter should be placed aseptically, should not be placed without any indication. Closed drainage system should be used. If contaminated, replace it. Catheter should not be irrigated unless absolutely necessary. Proper hand hygiene and aseptic precautions must be used when handling the catheter. Junction between the catheter and drainage system should be secured properly and should be removed as soon as possible. Now, last thing about VAP. New onset of pneumonia after 48 hours of mechanical ventilation is the definition of ventilator associated pneumonia. Second most common cause of healthcare infection. Incidence is 20 to 36%. Associated with high mortality, morbidity, increased length of PICU stay, hospital stay, excessive antibiotic usage which can further lead to antibiotic resistance. Endotracheal intubation is the most important risk factor for it, which increases the risk of VAP by 6 to 20 folds. Etiologies can be hospital acquired pathogens, Acinetobacter, Pseudomonas aeruginosa, Klebsiella species, E. coli or methicillin resistant Staph aureus. How do you prevent it? Two-prong approach, general measures to prevent HAI has to be practiced, and then there are certain specific measures to prevent VAP, that is the VAP bundle. There are 6 components, I will take one by one, just hurriedly. First is items to prevent iatrogenic spread of infection. So I have already told you, adherence to good hand hygiene practices, universal precautions को use करना है, use of appropriate isolation techniques based on the infectious organism has to be done. Second is to prevent the aspiration of gastric contents. Again, I have told you, elevate the head of bed to 30 to 45 degrees. Monitor the amount of the gastric contents, drain it. Avoid gastric distension. Third is improve oral hygiene. We have already discussed oral rinsing, cleaning with chlorhexidine, use of toothbrush and oral swabs in daily oral care. Fourth is to decrease the endotracheal tube risk factors. This is important. Use of inline suction equipment where appropriate and available. Suction of hypopharynx prior to ET suctioning and repositioning. Maintaining endotracheal tube cuff pressure and avoid unplanned extubation and reintubation. Fifth is to avoid contamination of respiratory equipment by using dedicated oropharyngeal suction equipment, prevention of accumulation of respiratory circuit condensate, prevention of contamination of ventilation equipment, change of circuits when visibly soiled or malfunctioning, and only sterile fluid should be used in humidifiers and nebulization. Last is to decrease the duration of mechanical ventilation. Practice neuromuscular blockade holidays 1 hour per day. Minimal sedation, use minimal sedation. Go ahead with daily assessment for the readiness to extubate. Appropriate levels of sedation should be maintained such that ideally the child is awake but comfortable. Over sedation will lead to weaning failure. Continuous heavy sedation should be avoided as this depresses cough reflex and spontaneous ventilation and also predisposes to aspiration of oropharyngeal contents or secretions. So the take home message is understand the importance of hand hygiene, practice the measures for prevention of common HAIs and practice the WAP bundle. These are the suggested references. My sincere thanks to all the contributors. Thank you.
Thank you, Dr. Sandhya, for this excellent presentation.
Thank you.
And there is only one question for you. The question is that after how many days we should change the
Foley's catheter. It can be we can keep it for 7 days at a go. Every 7th day we'll have to change it.
Thank you. And I think there is no other question. So thank you, Sandhya. Thank you very much.
Thank you.
So now I invite our next speaker, and this is the last talk of this training program and today's session. So the last talk is about the handling of the disease, and this will be taken up by Dr. Vineet. Dr. Vineet is assistant professor at GSVM Medical College, Kanpur. So I invite Dr. Vineet.
Thank you, ma'am. Thank you, ma'am. Okay, good afternoon to all listeners. In this last topic of COVID training, we will be going to discuss the management of the deceased. It includes the transfer of the dead body from the isolation room or ICU to the mortuary or for the cremation or burial. Death is almost always associated with a state of great disturbance, confusion, and uncertainty among the relative, and it must be very sensitively handled. As we all know, as per a study, COVID-19 third wave is likely to affect the pediatric age group more. We have around 3 crores of lab confirmed cases and around 3.99 lakhs of COVID confirmed death. The main learning scope of this topic is to shorten the knowledge gap on how to dispose of the dead body of a suspected or confirmed case of COVID-19. So how can we do this? We can do this by training all the staff that is identified to handle the dead body in the isolation area, mortuary, ambulance, and those workers in the crematorium or the burial ground for the infection prevention and control practices. And we should know that the main driver of transmission of COVID-19 is through the droplets. It is unlikely to be an increased risk of COVID infection from a dead body to a health worker or any family member who will follow the standard precaution while handling the body. And only the lungs of the dead COVID patient, that too if handled during an autopsy, can be infectious to the others. So, a skill to be enhanced. First is the hand hygiene. Second is the proper use of personal protective equipment. And third is the appropriate disinfection of all the environmental surfaces. So coming to the standard precaution that to be followed by healthcare worker while handling the dead body, as we already discussed, first is the hand hygiene. And second is the use of personal protective equipment, that is water resistant apron and gloves, mask and eyewear. Third is safe handling of the sharp object. Fourth is to disinfect the bag that housed the dead body and instrument and also devices that were used on that patient, and disinfect the linen and all the environmental surfaces. So first we will discuss the removal of the dead body from the isolation room or ICU. The health worker attending to the dead body should perform the hand hygiene and ensure the proper use of personal protective equipment before handle the dead body. All the tubes such as ET tubes, any drain, ICD like and catheter should be removed, and any puncture hole or wound that was resulted from the removal of the catheter, drain or tubes should be disinfected with 70% alcohol or 1% sodium hypochlorite solution, and then it should be dressed with some impermeable material to prevent any leakage of body fluid. Also, the sharp such as intravenous catheter should be cautiously handled, and it should be disposed of in sharp container. Plug the oral and nasal orifices of the dead body to prevent any leakage of the body fluid outside. If the family wishes to view the body at the time of removal from the isolation room or area, they may be allowed, but with following the standard precautions. So first, place the dead body in a leak-proof zipped plastic body bag along with the identification tag of the patient, which help us to identify the patient, and also it is marked with COVID-19 positive before being transported from isolation room or ICU to avoid any leakage. And after that, the exterior of the body bag should be decontaminated with 1% sodium hypochlorite solution. The body should be either handed over to the relative or taken to the mortuary as soon as possible. And all used and soiled linen should be handled with standard precaution and disposed of in the biohazard bag. All the used equipment should be autoclaved or decontaminated with disinfectant solution in accordance with the established infection and prevention control practices. And all the biomedical waste must be handled and disposed of in accordance with the biomedical waste management rules. The health staff who handle the dead bodies should remove the personal protective equipment and should perform the hand hygiene. And counseling of the family member, if needed, could be done, and sentiments should be respected. So coming to the environmental cleaning, in this scenario, environmental cleaning means the cleaning of all the contact surfaces of the dead body, that is the floor, bed, railing, side table, IV stand. It should be wiped with 1% sodium hypochlorite solution and give at least contact time of 30 minutes, and it should be provided after that by air. So handling of the dead body in the mortuary. Mortuary staff handling the COVID dead body should observe the standard precautions, and dead bodies should be stored in cold chamber maintained at approximately 4 degrees Celsius. The environmental surfaces and instrument and transport trolleys should be properly disinfected with 1% sodium hypochlorite solution, and after removing the body, the chamber, door, handle and floor should be cleaned with sodium hypochlorite, and mortuary must be kept clean. The embalming of the dead body should not be allowed, but if there is some unavoidable circumstances, it should be done, but with the minimal invasive technique. Autopsies on the COVID-19 dead body, like embalming autopsies, should also be avoided, but if there is some circumstances, it should be done with the following infection prevention and control practices. That is, the team should be well trained in infection and prevention control practices. The number of forensic expert and support staff in the autopsy room should be limited, and teams should use the full complement of the personal protective equipment, and negative pressure to be maintained in mortuary. The round-ended scissors should be used. PM40 or any other heavy-duty blade with blunted point to be used to reduce the prick injury. Only one body cavity at a time should be dissected. An unfixed organ must be held firm on the table and sliced with a sponge. Care should be taken to protect the hand. An oscillator saw with suction extraction of the bone aerosol into a removable chamber should be used for sawing the skull. And otherwise, a hand saw with chainmail gloves may be used if we don't have the this oscillator saw with suction extraction. Needles should not be reseated after the fluid sampling. Needles and syringe should be placed in sharp bucket. Reduce the aerosol generation as much as possible during autopsy using appropriate technique, especially while handling the lung tissue. As already discussed, it was most infectious. After the procedure, the body should be disinfected with 1% sodium hypochlorite solution and then placed in a body bag, the exterior of which will again be decontaminated with 1% sodium hypochlorite solution. The body thereafter can be handed over to the relative. An autopsy table to be disinfected as per the standard protocol. Now, transportation. The body secured in a body bag, exterior of which is decontaminated. Now it will pose no additional risk to the staff transporting the dead body to get infected. The staff handling the body may follow the standard precaution, and vehicle after transfer of the body to the cremation or burial will be decontaminated with 1% sodium hypochlorite solution. Now, at the crematorium or the burial ground, staff should be sensitized that COVID-19 does not pose any additional risk to get infected. The staff will practice the standard precaution of hand hygiene, use of mask and gloves, viewing of the dead body by unzipping the face end of the body bag may be allowed, but for the relative to see the body for one last time. All the religious rituals such as reading from the religious script, sprinkling holy water, and any other last rite that does not require touching of the body can be allowed, but bathing, kissing, hugging, etc. of the dead body should not be allowed. Large gathering at the crematorium and the burial ground should be avoided as a social distancing measure, as it is possible that the close family contact may be symptomatic and not shedding the virus at the time of crematorium or the burial. Electric or gas crematorium eliminate the chance of infection, and the funeral and the burial staff and family members should perform the hand hygiene after the cremation or the burial. As already discussed, cremation is recommended either by the electric or gas crematorium, and burial depending upon the religious sentiment. Burial should be done in thick airtight coffin placed at a depth of at least 4 to 6 feet below the ground. Area above and adjacent to the grave should be cemented and also marked immediately as an additional precautionary measures. The ash does not pose any risk and can be collected to perform the last rite. You collected my data from the following references. Anyone interested can go through these links for further study. My sincere thanks to all the contributors. Thank you, ma'am.
Thank you, Dr. Vineet, for this excellent presentation.
Welcome,
And there is one question for you. The question is, which part of the dead body is most infectious?
If we follow the standard precaution, the only part that is the most infectious is the lung, that too only during the autopsy.
Yes. And there is no more questions. So thank you, Vineet.
Thank you, ma'am.
So with this, we come to the end of this day 4 long training program. And I hope this must be useful to all of you. And I thank all the participants for their active participation. So my sincere thank to DGME sir and to Dr. NC Prajapati sir, who started this training program, and this training program is the need of the hour. And I thank our HOD, Dr. Shaili Avasthi ma'am, and she's the main person behind the academic program of this training program. So I also thank for all the person who are helping us for this training program, Dr. Suyog, Mr. Neeraj, and the Mamta team, who is giving excellent technical support for this training program. Thanks to all the speakers again. Thank to all the moderators. And thank you, Shalini.
Thank you very much.
Thank you. Thank you. So with this, we come to the end of today's training program. And as you know, that there is a post test after this. And before we start post test, and all of you know that the post test is mandatory. So before we start the post test, Mr. Neeraj will brief you about the post test. Thank you very much.
Thank you, ma'am. This is basically a sample of a message. You can see I've shared my screen. It contains basically 4 set of links. In the last, there's a link of the post test. It is mentioned the Google link for post test for day 4. You have to click on this link to submit your post test. If it's not coming on blue color, I request you to please save the number from which you have received this messages. I'm also showing you how it looks on WhatsApp. You can see only 3 links are visible. You have to click on this read more. Then only you can see the post test link at the last. And if you have clicked on this link now or before it's get activated, currently it's not activated. So you have to close that tab of your browser or Chrome, and you have to click on this link when it's activated, so that your general details like your name, mobile number, email ID, and also your participant ID should come pre-filled. Okay, as the timing is from 3:40, so the post test will be of 20 minutes. I'll be activating the link, and after that you have to click on the link. And if you are facing any issue with the post test, you can message on the number from which you are receiving the WhatsApps. So I'm activating the link. Link is activated. Please go submit your post test. And if you have already clicked on the link and the page is saying the Google form is not accepting the responses, you have to click on close that tab and click on the link again. Post test link is activated. Please submit your post test. And if you are facing any issue, you can message me on the WhatsApp from which you are getting the links for the training. Thank you all. Closing meeting. Certificate will be shared on WhatsApp with all those who have submitted their post test.